All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's episode is going to be kind of a culmination of all things critical care vasopressors, a comprehensive overview to these medications. This is a critical topic for anybody who works with patients on vasopressors, whether you're a student, trainee, physician, MP, PA, nurse, RT, anything in between. All these medications are so critical to have a good understanding on. Within each medication, we're going to go through the mechanism of action. We're going to go through indications, contraindications, dosing, pharmacokinetics, clinical pearls, hemodynamic effects, practice questions, a whole bunch of good stuff. It's a long episode, so it's going to be divided by chapters. You could skip around if you'd like to. Chapter 1 is going to be Norepinephrine, Chapter 2, Vasopressin, Chapter 3, Angiotensin II, Chapter 4, Oral Midodrine, Chapter 5, Methylene Blue, Chapter 6, Hydroxocobalamin, and Chapter 7 in yellow, because you can barely see it, because I don't even really use it, is Dopamine. So hopefully you enjoy this. Let us know what thoughts or questions you have. We have all the study guides, more practice questions on our Patreon page, linked in the episode description. And no further ado, let's hop into Chapter 1, Norepinephrine. Norepinephrine. What is norepinephrine other than the workhorse of critical care and ICU medicine? So norepinephrine is also known as noradrenaline. Okay, it is a first-line vasopressor, really first line for a lot of different things used in the management of shock, particularly septic shock. Now, norepinephrine is a catecholamine. All right, so catecholaminergic, catecholamine, and adrenergic. These are all, did we spell that right? We might have spelled it wrong, but you get the point. These are all kind of synonyms. So when it comes to vasopressors, there's catecholamine, also known as catecholaminergic, also known as adrenergic vasopressors that work on catecholamine receptors. Things like norepinephrine, epinephrine, phenylephrine, okay? All these will be different vasopressors we talk about in this series. But these are different than the non-adrenergic or non-catecholaminergic vasopressors. These are vasopressors that do not work on catecholamine receptors. Things like vasopressin, Angiotensin II, AG2, Methylene Blue, or Hydroxocobalamin. All these work on different pathways that are not catecholamine driven. Whereas norepinephrine, the one we're talking about today, it is a catecholamine. It primarily acts on the alpha adrenergic receptors, causing vasoconstriction, and to a lesser extent the beta-1 receptors, which support cardiac output. And these are two things we're going to go into a lot more in this video and other videos, so stick around. Norepinephrine is recommended by major critical care guidelines as the vasopressor of choice in most cases of distributive shock. That biggest one that we talk a lot about being septic shock. We've talked about septic shock on this channel a whole bunch of times in our critical care playlist. So clinical uses for norepinephrine is a nice transition into that. The biggest one is septic shock. This is shock you get from a systemic infection in your body. Again, we've talked about it in separate videos. If you're interested in this episode's description, definitely check it out. It'll be in the critical care medicine playlist, which will be linked in this episode's description. It's a first-line vasopressor, and you usually use it to maintain a MAP, a mean arterial pressure, above 65 millimeters of mercury, which is this magic number we try to keep the MAP above for patients with septic shock. And it's first line. It's titratable. You start it, the nurse titrates the dose to try to achieve this MAP. You can use it for other vasodilatory shock states too, things like neurogenic shock when you have a cervical spine injury that causes dysregulation of your sympathetic system and can lead to hypotension. Post-cardiac surgery patients sometimes get vasodilated. Cardiogenic shock, you can use norepinephrine too when hypotension or low blood pressure is predominant. This is a little more complex because there's a lot to consider in cardiogenic shock, which we actually should put out a video on cardiogenic shock. We haven't before. If you're interested in that, let us know and we can dive into all the intricacies of cardiogenic shock. And then hemorrhagic shock. This is also highly debated. The treatment of hemorrhagic shock is to give them blood, right? And some institutions, places, and folks would suggest you should not give norepinephrine for hemorrhagic shock. Other folks would suggest, and I'm going to actually cross out volume and say blood resuscitation here. Other folks would suggest that at some point you might become catecholamine depleted in hemorrhagic shock. And as such, norepinephrine may help restore some of that catecholamine sensitivity that is leading to vasoplegia or dilation of the blood vessels that is not just driven by bleeding. So this is highly debated, but something to consider. Definitely, though, not something that is first line. Blood, and more blood is first line for hemorrhagic shock every time. All right, mechanism of action. How does it work? Well, the two main receptors are one, the alpha-1 adrenergic receptor. If we look at a blood vessel, right, blood vessels have kind of smooth muscle cells all over them that can help vasoconstrict. And the alpha-1 adrenergic receptor helps these blood vessels vasoconstrict, that helps them contract. And that will increase the systemic vascular resistance, or the SVR, and it'll raise the blood pressure. It'll increase the MAP, or the mean arterial pressure. So the main mechanism that norepinephrine uses to increase the blood pressure and treat shock is the alpha-1 adrenergic agonism. That's a mouthful, but it essentially causes vasoconstriction of the peripheral blood vessels, which increases the systemic vascular resistance and increases the mean arterial pressure. The other mechanism that you'll often see in catecholaminergic, adrenergic vasopressors like norepinephrine is beta adrenergic agonism, or beta receptors. And beta receptors are actually in the heart. That's a picture of a heart. And beta-1 receptors in the heart cause an increase in myocardial contractility. It increases cardiac output. It increases how hard that heart is squeezing. It can also increase heart rate a little bit. So it has inotropic effects, which is what we call increase in contractility. And then it has some mild chronotropic effects, which is increase in heart rate. This is less than epinephrine and less than dopamine, which isn't commonly used anymore. But norepinephrine does have some myocardial contractility. The strong effect is alpha-1 peripheral blood vessel vasoconstriction. And then there's a mild to moderate beta-1 increase in myocardial contractility and heart rate with norepinephrine. Okay? So bottom line here is norepinephrine increases the mean arterial pressure by raising the systemic vascular resistance more than it increases the cardiac output by increasing myocardial contractility. So alpha-1 effects are much more than beta-1 effects, but it does have some of each. How do we dose it? How do we administer it? Well, norepinephrine is administered as a continuous infusion. All right, so it's continuously going through an IV line. We typically start it at 0.01 to 0.05, and this is the dosing, micrograms per kilogram per minute. So it is weight-based. Now, some institutions don't report it as weight-based. They'll take out the kilograms, and let's just say it's a 100 kilogram person. They'll say that, 0.01 times 100 will start at 1 to 5 micrograms per minute, right? Because if you just multiply 100 kilograms times that 0.01 to 0.05, that's how you kind of can get that number. But some institutions don't use the kilograms. They just titrate it based on micrograms per minute. And it's, started at 3, 5, 1 microgram per minute. And then you titrate it up, by, you can do the same thing. By 5, you can increase it by 5 mics. You can increase it by 3 mics per minute without the kilograms. Most commonly, though, it's dosed in kilograms per minute. So starting at 0.01 to 0.05 micrograms per kilogram per minute. Typical range is 0.05 to 1 microgram per kilogram per minute. For those non-weight based, that would be 100 times this. So this would be like from typical range would be 5 to 100 micrograms per minute if it's not weight-based. Now, you can go above this. There's no maximum that exists that says that, there's only this much norepinephrine you can give. Now, there is some literature on the maximal amount of norepinephrine that's efficacious, that works, and that where higher doses don't do much. But even that literature is really soft, really tough to know what that actual maximal dose is. So maximum doses vary by institution, There isn't any real set maximum where you cannot go above this. Some institutions can go as high as 3 micrograms per kilogram per minute. That'd be up to 300 micrograms per minute in someone who is 100 kilograms, but that's super high too. We've been at different institutions and we haven't found an institution that goes that high, but you can go very, very high. You can go very, very high. It most likely does not continue to work after you get above a certain dose. What that dose is, though, is tough to say. So when you titrate it every 2 to 5 minutes based on the map. And usually you're going to try to titrate it to a map of 65 millimeters of mercury. That's particular for septic shock. And you titrate slowly, watch for signs of ischemia, but 2 to 5 minutes, because that's the time it takes to kick in. Right? So if you're titrating it faster than every 2 to 5 minutes, you have not given enough time for your previous adjustment to kick in yet. And you might get this kind of rebound hypertension. Right? You'll see that someone's really, really sick, their blood pressure is really low, and you're titrating up the norepinephrine every 30 seconds, and all of a sudden their blood pressure is super high because you've kind of over-titrated it because you were going too quick. Just quick preparation, sometimes interesting just to understand. It's pre-mixed bags, 4 milligrams and 250 cc's of D5W or NS, so it's either sugar water or normal saline that it comes in. And there's different concentrations you can have. You can have 8 milligrams, you can have, I think, 4, 8, 16, and maybe even 32 milligrams per 250 cc's. Don't quote us on this. There's certainly the 8 and 16 doses, and then we think there are 4 and 32 as well. But obviously, the more concentrated it is, the higher risk it might extravasate in a peripheral IV. So if you're running it peripherally and you're at these higher concentration bags, there's a higher risk of extravasation. The suggestion is that you administer it via central line. There's been a lot of data that's come out about this, and it does look like the lower concentration bags, a lot of the research is on the 8 milligrams to 250 cc's, may be safe in a peripheral IV up to a certain dose. What that dose is tough to say. Like many things, it might be somewhere in the realm of 20 micrograms per minute, but is tough to say. But most likely, it is safe to run norepinephrine in a peripheral IV at these lower concentrations and lower doses, at least for a set period of time, if done in the right way. Okay, but it's got to be done the right way. It's got to be the right kind of IV. It's got to be in the good location. It's got to be watched really closely. So central line is kind of the old adage, and it's certainly safe to give norepinephrine through a central line, but a peripheral probably is okay, at least in the right context. All right, pharmacokinetics. Onset of action. It starts working in 1 to 2 minutes, and the peak effects within 5 minutes, which is why you don't want to titrate it faster than every 2 to 5 minutes, because you won't have time to see that peak effect. It lasts less than 5 minutes, which is why you need a continuous infusion. So once you turn it off, it'll stop working in just a couple of minutes. Its half-life is 2 to 5 minutes. So, if we use 5 half-lives, it just is literally a handful of minutes before it's kind of totally out of your system and not working. It's metabolized by COMT and MAO in the liver and other tissues, and then it's eliminated renally and hepatically. But those are inactive metabolites. So these enzymes in the liver that metabolize norepinephrine tend to keep working. Now, if you had a really, really bad liver failure, maybe norepinephrine would stick around longer. But typically, it's metabolized into these inactive metabolites and then excreted from the kidneys and liver. So if you have really bad renal dysfunction, the metabolites are inactive that you're trying to pee out. So if you're not making good urine because you have kidney injury, you're just holding on to some of these inactive metabolites. These aren't still having the effects of norepinephrine in your body, if that makes sense. What about the evidence? Well, there's been a whole bunch of studies and guidelines kind of on norepinephrine. The Surviving Sepsis campaign, which is one of the kind of guidelines we look to for septic shock data, recommends norepinephrine as a first-line vasopressor in septic shock. This is fairly universal. We are not personally aware of any guidelines that suggest something other than norepinephrine as a first-line vasopressor in septic shock. And then you want to titrate it to a map of 65 millimeters of mercury in septic shock most times. And obviously, if volume, resuscitate them as you see fit. There are a couple trials that have looked at norepinephrine in a meaningful way, often comparing it to dopamine. Dopamine was a vasopressor that we used a lot more in the past that we don't commonly use anymore for the reasons we're about to talk about. But there was a CATS trial in 2007 and the SOAP2 trial in 2010. And essentially both of them showed that norepinephrine was better. It had fewer arrhythmias and lower mortality in cardiogenic shock patients compared to dopamine. And then it had lower rates of arrhythmias and possibly a mortality benefit in cardiogenic shock. But so norepinephrine versus dopamine in shock states in the SOAP2 trial, including septic shock, had less arrhythmias, and then it might have a better mortality than dopamine in cardiogenic shock. So this is why we use norepinephrine rather than dopamine in shock states, including septic shock, primarily the SOAP2 trial, but also the CATS trial. There's been meta-analyses done as well. Norepinephrine improves outcomes over other vasopressors, especially versus dopamine, which is why we don't use dopamine anymore. Better hemodynamic stability, lower ICU mortality, et cetera, et cetera. So norepinephrine, first-line vasopressor in most shock states, definitely first-line vasopressor in septic shock, and definitely is better than dopamine, causing less arrhythmias and possibly better mortality. Side effects of norepinephrine, like many catecholinergic vasopressors, tissue necrosis, right? This causes vasoconstriction. So if it gets out into the tissues, it extravasates out of the IV, it can cause tissue necrosis. Now, this can be treated. Most times it is quote unquote not that bad. But it can be bad, so it is something we've got to be cognizant of and aware of. It can cause ischemia too, right? Whether it's in the digits, intestines, or kidneys at high doses. When it's with vasopressin, so when it's combined with vasopressin, which we talked about in one of our other vasopressor videos, it has an increased incidence of ischemia. So you got to be watching the fingers and toes, thinking about the gut, the kidneys, all that kind of stuff. And then it does have that beta-1 adrenergic effect on the heart, right? We said beta-1 increases contractility and increases heart rate. So it can cause tachydysrhythmias, but it is less of a cause of tachydysrhythmias as compared to dopamine and epinephrine, which both have increased incidence of tachydysrhythmias. So norepinephrine can cause tachydysrhythmias like atrial fibrillation and SVT and all that, but less so than dopamine or epinephrine. If you titrate it too quick, like we talked about, you can get this reflex hypertension. And in that context, sometimes it can cause a reflex bradycardia, although this is not very common. The antidote for extravasation is phentolamine. This is what you'd inject into the skin around where the norepinephrine extravasated. And you should do this as quick as you can to try to treat that and limit tissue necrosis. So quick summary on norepinephrine to end the video here. It is a catecholinergic vasopressor, also known as adrenergic. It works on catecholamine receptors. Its mechanism of action is alpha-1 vasoconstriction in the peripheral blood vessels, leading to increase in systemic vascular resistance and increase in the mean arterial blood pressure. Secondarily, though, it does also affect the beta-1 receptors in the heart that cause increase in contractility, which can increase cardiac output, and also some mild increase in chronotropy, which can increase heart rate. Its primary use is in septic and vasodilatory shock states. Your starting dose, which is usually weight-based, is 0.01 to 0.05 micrograms per kilogram per minute. Your goal map is typically more than 65 millimeters of mercury. This is particular to septic shock, though, and there's still some caveats there. Best route is through a central line, although there's growing evidence on peripheral IVs and use of norepinephrine is probably safe if done in the right way. And then the evidence supporting norepinephrine use is really strong, especially compared to other vasopressors like dopamine. So norepinephrine is the workhorse of our vasopressors. You're going to see this a ton in the clinical arena for patients who are sick. It's really important to know about it. It's important to know how it works, what to look out for, how to use it, and all that jazz. Again, for this study guide or practice questions, go to our Patreon page. What is vasopressin? Well, vasopressin is also known by two other names. Some of these may be more familiar, some of these may be less familiar. The first is arginine vasopressin, or AVP, and the second is antidiuretic hormone, or ADH. We'd assume more people would be familiar with ADH as part of many of the pathways we learn about in clinical training. Oh, let's allow that. And vasopressin is an endogenous hormone. It's a hormone that we all have circulating in our bodies, and it plays a major role in both fluid balance and vascular tone. This might start to explain for those of us really enthralled by this video and why vasopressin is used as a vasopressor, because it controls things like fluid balance and things like vascular tone, both things that can increase your blood pressure, your BP. So in critical care, in the ICU, or for patients who are critically ill, vasopressin is used as a second-line vasopressor. All right. This is often added to norepinephrine, brand name Levophed, in the treatment of vasodilatory shock, especially septic shock. And we're going to get into this a lot more as the video progresses. What is interesting about vasopressin and why we use it as a second-line vasopressor is that it's not catecholaminergic or not adrenergic, right? So when we think about vasopressors in general, we think about two kind of different larger categories, and there's multiple larger categories, but one are catecholaminergic, catecholamine. This is also known as adrenergic, okay? And these are a lot of the vasopressors that are first line, right? Things like norepinephrine, epinephrine, phenylephrine. All these are catecholaminergic or adrenergic vasopressors. Their mechanism of action uses catecholamines. But there's other types of vasopressors as well that use different pathways, different mechanisms. And vasopressin is one of those, right? It is ADH. It is an endogenous hormone involved in fluid balance and vascular tone. All right? It is not a catecholaminergic vasopressor, which means it is non-adrenergic. So it's helpful in patients who are already on catecholaminergic or adrenergic vasopressors like norepinephrine, because adding vasopressin uses a different pathway, a different mechanism. And it can be helpful sometimes in this catecholamine refractory hypotension that you can see, all right, as a second line. So diving deeper into the mechanism of action of vasopressin. So there's three different receptors vasopressin often acts on, okay? V1A, V2, and V1B. All right, V1A and V2 are probably the more important receptors when it comes to vasopressin's action as a vasopressor, right? V1A is in vascular smooth muscle. So why does this matter? Well, our blood vessels have all this smooth muscle around them, okay? And all this smooth muscle helps vasoconstrict those blood vessels, right? If that smooth muscle constricts, it causes the blood vessels to vasoconstrict. And this can sometimes increase blood pressure. This is how a lot of the catecholaminergic vasopressors work, right? Alpha-1 receptors causes vasoconstriction. Vasopressor, though, acts on V1A receptors on vascular smooth muscle, still leading to vasoconstriction, which increases your SVR, that stands for systemic vascular resistance, the resistance of your vasculature, and that increases your MAP, your mean arterial blood pressure, which is one of the goals of vasopressors, right? To increase the MAP, to increase the blood pressure. Vasopressin, though, has another mechanism of action as well that contributes to increasing the MAP, and that is the V2 receptor, which is on renal collecting ducts. All right, the collecting ducts are in the kidney nephron, and they control how much solute and electrolytes and water and urea go in and out, how much you excrete and urinate out versus how much you reabsorb and keep in the blood vessels. So the V2 receptor in the renal collecting ducts actually leads to water reabsorption. This can increase your intravascular volume, okay? And if you are in septic shock or hypovolemic shock, or you're in a shock state where increasing that vascular volume will be a benefit, this can help increase the blood pressure too. Now, this is a minor mechanism, right? You can still use vasopressin in shock states that do not require increases in intravascular volume. So you shouldn't shy away from vasopressin just because you think, oh, vasopressin is going to increase the intravascular volume. All right, it's a minor mechanism. You can still use vasopressin. The primary mechanism is this V1A receptor that leads to vasoconstriction. There is then a third, even more minor mechanism. That's the V1B receptor. This is in the pituitary gland, and it actually stimulates ACTH release. An ACTH, for those of you unfamiliar, is a hormone that downstream increases the secretion of cortisol or steroid hormone. Again, this is a minor role, but vasopressin does do that as well. So there's kind of these three separate mechanisms of action of vasopressin. One being the vascular smooth muscle, causing vasoconstriction. 2 being in the renal collecting ducts, causing water reabsorption. And 3 being in the pituitary, stimulating ACTH release that can increase cortisol levels. So in shock states, vasopressin helps raise the mean arterial pressure by constricting peripheral blood vessels through that V1A receptor and augmenting intravascular volume via water retention via that V2 receptor. All right, so non-adrenergic, non-catecholaminergic pathways. How do we dose vasopressin? How do we administer it? Well, typically in the ICU, vasopressin is statically dosed. All right, so you put it at 0.03 or 0.04 units per minute fixed dose. It is not titratable. It can be titrated, but typically we order it as fixed dose. So the nurse isn't bedside increasing it or decreasing it depending on the blood pressure, right? We're not going from 0.03 to 0.04 to 0.05 to 0.06. We're leaving it at that fixed dose. So vasopressin is usually added as an adjunct to norepinephrine because the norepinephrine is titratable. This is the one you're going to titrate based on the blood pressure, whereas the vasopressin tends to be not titratable. Different hospitals use different fixed doses. 0.03 or 0.04 are both perfectly reasonable. All right. The higher the doses of vasopressin, there is somewhat of an increased risk of ischemia, either in the fingers, toes, or in the bowel as well. But 0.04 is still perfectly reasonable, but at that little bit of a higher dose, there is some increased risk of ischemia. So 0.03, 0.04 units per minute, fixed dose, not titratable. And you administer it through continuous IV infusion. Most often that's through a central line that is preferred. Some people can run vasopressin through a peripheral IV, a PIV, peripheral intravenous catheter, but this is kind of untested in a meaningful way. There's not a lot of studies on whether this is safe or not. So it's best done through a central line, and that's probably how it's most often administered to folks. Okay, pharmacokinetics. So the onset for vasopressin is actually a little bit interesting. The onset, it takes about 10 to 20 minutes before it kicks in. Certainly, that's when it kind of gets to its peak. It might kick in faster than that, but you really do have to wait 10 to 20 minutes before you see the full effect of vasopressin, how much it's going to help or not help the blood pressure. And then the half-life is 10 to 20 minutes, so after you turn it off, it'll still stick around for another 10, 20 plus minutes, right? So 5 half-lives is getting closer to an hour, which is when they say usually most drugs go on is in 5 half-lives. So 5 half-lives, T1/2 would represent half-life, is about an hour depending on what you choose from that 10 to 20 minutes. It is hepatically and renally metabolized. So if you have patients with renal failure or they're end-stage renal disease, or you have patients with a liver failure, they're not going to metabolize vasopressin as quickly, which means it might stick around longer, right? That half-life is going to be a lot longer. So you might turn the vasopressin off, but it might be circulating for more than that 60 minutes if you have a renal failure or liver failure. And it's eliminated either urinary or hepatic, right? Kind of same mechanism. So same thing holds, renal or liver failure, it's going to stick around a lot longer. Clinical uses. The most common clinical use is most often septic shock, when you're in shock from a severe infection. And in that case, it's that second line vasopressor. So you start norepinephrine, and if the norepinephrine is not working, you're going up and up and up on your norepinephrine doses, that's when you start vasopressin. Guidelines out there, if we were to use the Surviving Sepsis Campaign guidelines, they stay to start vasopressin when you're between 0.25 and 0.5 micrograms per kilogram per minute of norepinephrine, norepinephrine. This is just expert consensus. There's no magic here. There's actually some complex evidence that could in the future support starting vasopressin earlier, but as it stands right now, at least the Surviving Sepsis campaign suggests starting the vasopressin after you are on more than 0.25 to 0.5 micrograms per kilogram per minute. If you don't do weight-based norepinephrine dosing, this for, your 70 kilo person is going to be something like, 20 micrograms ish per minute, all right, of norepinephrine. And that's when you usually start vasopressin, either at the 0.03 or 0.04 fixed dose. You can also use it in vasodilatory shock, all right, that post-cardiac surgery patient, the spinal or neurogenic shock patient. Cardiac arrest, it was previously actually an ACLS, advanced cardiac life support. This is a big algorithm commonly used to treat patients with cardiac arrest, but it was removed in the 2020 guidelines, so it's no longer recommended in cardiac arrest. All right, esophageal variceal bleeding. Some people use it off-label to vasoconstrict the splanchnic blood vessels. Those are the blood vessels in kind of the gut that can be involved in variceal bleeding. This isn't something commonly done, but it is something that can be done. And it's via that V1 receptor, causing that smooth muscle vasoconstriction of those splanchnic blood vessels in the gut. And then diabetes insipidus, okay? So diabetes insipidus, or DI, this is not being used as a vasopressor here, but you can, via the V2 effect, right, if we go back up to receptors, V2 was one of the receptors used, and that's caused water or reabsorption, right? So this essentially helps you in patients with diabetes insipidus reabsorb water so that you don't have as much hypernatremia. So outside the confines of this discussion, but diabetes insipidus is where you're urinating out a ton of water, so you have increased water excretion. That leads to your sodium being high. So the V2 effect with vasopressin just helps you hold on to that water so that you have less water excretion to help you normalize your sodium. But for the sake of critical care stuff and vasopressors, these two are the biggest ones, septic shock and vasodilatory shock. If we were to get into some of the, more complexities of this, sometimes we like vasopressin a little bit more in patients with right heart failure. Right heart failure patients are pumping blood against the lungs, right? The pulmonary vascular resistance, the PVR, is the afterload of the right heart. This is complex. If this is too complex, feel free to blank out during this part. But catecholaminergic vasopressors like norepinephrine cause vasoconstriction of those pulmonary blood vessels, whereas vasopressin is thought to not cause as much vasoconstriction of the pulmonary blood vessels, so it won't increase the right heart afterload. So in patients with right heart failure, where you don't want the right heart to kind of have to pump against more resistance in the lungs, vasopressin is sometimes a nicer drug than the catecholaminergic vasopressors like norepinephrine. But that's a more complex topic. If that's something you're interested in, we're happy to put a whole video out on it. Let us know. I'm happy to do that. Evidence and guidelines. There is a trial that's worth knowing when it comes to vasopressin. It's called the VAST trial. It was published in the New England Journal of Medicine back in 2008. And it looked at norepinephrine versus norepinephrine plus vasopressin in septic shock. And there's actually no mortality difference between the two groups. So adding vasopressin to norepinephrine did not improve mortality versus norepinephrine alone. But in less severe shock states, vasopressin may be reduced mortality. Now, this is a loaded statement. We're actually going to cross it out, but it's worth knowing. It was not powered for this, but this is what we were implying. We're maybe starting vasopressin earlier rather than waiting until you get to that 0.25 to 0.50 micrograms per kilogram per minute of norepinephrine. Maybe starting it earlier, the vasopressin earlier would be better, but we don't know that. In the vasopressin group, there were lower rates of arrhythmias. It did decrease norepinephrine doses being used, so it seems like adding vasopressin, most likely at these higher doses, does not improve mortality, but it might decrease the number of arrhythmias a patient's going to have. It also might decrease the amount of norepinephrine they need. And maybe if you start the vasopressin earlier, maybe, we do not know this, maybe that might have an effect on mortality, but that will require additional studies. As we mentioned, the Surviving Sepsis campaign in 2021 did recommend adding vasopressin to norepinephrine when MAP goals are not met, and that norepinephrine dose when it suggests starting is that 0.25 to 0.5. We said this a bunch, micrograms per kilogram per minute, which is like around 20 micrograms per minute of norepinephrine, okay? That's when the Surviving Sepsis campaign at least suggests starting vasopressin. 0.03 is a dose often used, or 0.04 is the other dose used, but at the higher dose, there's a little bit increased risk of ischemia of the digits in the gut. ATHOS-3 is a trial that looked at angiotensin II, which is a different vasopressor that we're going to talk about, and it compared it to different vasopressors. One of those was vasopressin. This is probably not that helpful. We don't think it probably contributes too much, so we're going to cross it out. Okay, what else? Side effects and complications of vasopressin. As we already implied, vasopressin can increase ischemia of everything, the digits and the gut being two of those things. So increased risk of mesenteric ischemia, increased risk of digital ischemia. All right, it can cause hyponatremia. Now, why is that if you think about it for a second? Well, the V2 receptor, we said, increases water reabsorption in the kidney. So if you're increasing free water reabsorption, that can drop your sodium. So it can lead to hyponatremia. Some patients, this is very rare, but it can cause coronary vasoconstriction. That can lead to cardiac ischemia, but that's not something we often think much about. And then if it extravasates, so if you use a peripheral IV and it gets out of that peripheral IV into the skin and extravasates, it can cause tissue necrosis. Less common than norepinephrine, maybe, although we might even cross that one out as a maybe. And then a central line is preferred for vasopressin. So just a comparison, norepinephrine compared to vasopressin are two kind of first-line agents we often use for vasopressors. Norepinephrine is adrenergic, right? I said that a couple times. It's a catecholinergic vasopressor, just like epinephrine and phenylephrine. Whereas vasopressin is a non-adrenergic, right? It does not act at catecholamine receptors. Vasopressin acts at V1, V1A, and V2. Norepinephrine acts at alpha 1 and beta 1, which we'll talk more about in the norepinephrine video. Titration, this is fixed dose. Vasopressin is not titrated, whereas norepinephrine is titrated to a MAP goal most commonly. The arrhythmia risk is lower for vasopressin because it is not catecholinergic, so it does not affect some of those receptors in the heart like beta 1 that can increase the risk for arrhythmias. So it has less effect on the heart for arrhythmias, whereas norepinephrine and all the catecholinergic vasopressors that have cardiac receptor effects, like the beta receptors, do increase risk for arrhythmias. People say that vasopressin works better when a patient is acidemic as compared to its catecholinergic vasopressors like norepinephrine. How much of that is clinically meaningful is tough to say, but theoretically vasopressin maintains its effect even in acidemic environments compared to a vasopressor like norepinephrine, which theoretically does not work as well in acidemic environments. And then vasopressin is second to line in septic shock. Norepinephrine is first line in septic shock. So in summary, vasopressin is an endogenous hormone. It works on the V1 receptor primarily, which causes vasoconstriction. It also works a little bit on V2, which causes free water reabsorption. The usual dose is 0.03 units per minute fixed. Some institutions use 0.04 units per minute. It's a second-to-line vasopressor in septic shock as its primary use, best combined with norepinephrine. High doses can cause ischemic complications, both mesenteric ischemia in the gut and digital ischemia. And then there is some evidence, particularly the VAST trial, that has led to vasopressin being included in the Surviving Sepsis guidelines as an add-on to norepinephrine. If a patient's on norepinephrine at greater than 0.25 to 0.5 micrograms per kilogram per minute, the Surviving Sepsis campaign would suggest adding on vasopressin fixed dose. So just a little tip, when norepinephrine alone is not reaching the target MAP in a patient in septic shock, Add vasopressin. Consider adding it even a little earlier, but especially as norepinephrine is exceeding about 15 micrograms per minute, which is right around that 0.25 to 0.5 micrograms per kilogram per minute dose. What is angiotensin II? Well, angiotensin II is an endogenous hormone. We all have it in our body. And it's involved in the renin angiotensin aldosterone system, more commonly referred to as the RAS system, which many of us are probably familiar with. Depending on how close we are to our training or schooling, some of these memories might have faded, some of them might not have. But that system, the RAS system, plays a key role in our vascular tone and blood pressure regulation, which based on this, if you're thinking ahead, this makes sense why angiotensin II, we're going to be abbreviating it AG2, is used as a vasopressor, a medication to increase the blood pressure, keep the blood pressure up in patients with shock. So in critical care, synthetic angiotensin II, brand name Giopreza, that's their brand name, it's copyrighted and all that kind of stuff, is used as a vasopressor for refractory vasodilatory shock, particularly in patients who are unresponsive or less responsive to first, second, and third line vasopressors such as norepinephrine, vasopressin, and epinephrine. All three of these we talked about in previous episodes in our vasopressor series. So definitely check out that playlist or our critical care or our pharm playlist in the episode description. So when we think of angiotensin II, it is a non-catecholamine vasopressor. And as we've talked about in previous episodes, when we think about vasopressors in general, we often divide them into catecholamine. This is synonymous with adrenergic or catecholaminergic. These all are kind of synonyms. And then non-adrenergic. And the catecholaminergic or adrenergic vasopressors, as one might guess, their mechanism is catecholamine driven, right? These are norepinephrine, epinephrine, phenylephrine. Whereas non-adrenergic or non-catecholaminergic vasopressors, as one might guess, function outside of the catecholamine pathways. These are things like vasopressin, angiotensin II, which we're talking about today, methylene blue, hydroxocobalamin, which are all things we've talked about in this vasopressor series. So angiotensin II is a non-catecholamine, also known as a non-adrenergic vasopressor. It works outside of catecholamine pathways, particularly in this case, as we talked about the RAS pathway, renin angiotensin aldosterone. So it's an alternative vasopressor pathway. These non-adrenergic, non-catecholaminergic vasopressors tend to be used as kind of second or third or even fourth line vasopressors because they work on different pathways outside of the catecholamine pathway. Whereas these catecholaminergic vasopressors, particularly norepinephrine, tend to be our first line. So when there's catecholamine resistant hypotension, you've started norepinephrine, you're up titrating it, it's not helping, that is when we usually grab for an vasopressor from an alternate pathway, a non-catecholamine vasopressor. Most classically, second line is vasopressin, although in this episode today, we're talking about angiotensin II, which is another one. So mechanism of action more specifically for angiotensin II. We've already established it's a non-catecholaminergic or non-catecholamine vasopressor. Sorry, I need a little swig of the coffee there. And it primarily works on AT1 receptors. These are vascular smooth muscle receptors. We have all these peripheral blood vessels, and all these blood vessels have all this smooth muscle all around them. And that smooth muscle, when it constricts, it squeezes this blood vessel, makes it smaller, and it vasoconstricts it. And that increases our systemic vascular resistance and often increases our mean arterial blood pressure. So angiotensin II acts on these AT1 receptors in these smooth muscles, causing those smooth muscles to contract and vasoconstrict their blood vessels, which increases systemic vascular resistance and increases the mean arterial pressure. Okay. Angiotensin II, though, also works on the adrenal cortex. It stimulates aldosterone release, and this causes sodium and water retention, which can increase your intravascular volume, which, depending on the pathology for your hypotension, this might increase your MAP, your mean arterial blood pressure, as well. Now, this is a secondary pathway. It's not as robust as this AT1 receptor pathway that causes vascular smooth muscle constriction, but it does happen, right? So if a patient's fluid overloaded, could you still give them angiotensin II? You could. And with the sodium water retention, which leads to increased intravascular volume, cause something detrimental to happen? Probably not, because most of the pathway is vascular smooth muscle vasoconstriction, but there would be some degree of aldosterone release that would lead to sodium and water retention. And then the third path in which angiotensin II works is sympathetic system in the brain. It enhances norepinephrine release. So there is some echo here of adrenergic or catecholaminergic, catecholamine-driven pathways, because it actually stimulates in the brain to enhance norepinephrine release. So it's really interesting. There's kind of these three really separate pathways: AT1 receptors and vascular smooth muscle leading to vasoconstriction, adrenal cortex functionality leading to increased aldosterone release, which then leads to sodium and water retention in the blood vessels and an increase in intravascular volume, and then centrally in the brain enhancing norepinephrine release, which then causes some catecholamine-driven vasoconstriction. One thing to note in this renin-angiotensin aldosterone pathway is that angiotensin II acts downstream of ACE. ACE stands for angiotensin converting enzyme. And for those really paying attention, one might remember that a lot of patients are on ACE inhibitors for their blood pressure, things like lisinopril or enalapril. And one might astutely say, well, does angiotensin II work on patients who took ACE inhibitors recently? And the answer is it does, because it works downstream of that. So it acts downstream of ACE, so it's effective even in patients with impaired RAS or those taking ACE inhibitors. It should still be effective and work because it acts downstream. All right, dosing and administration of angiotensin II. Well, the initial dose you usually start with is 20 nanograms per kilogram per minute in an IV infusion. And you can titrate it up to 80 nanograms per kilogram per minute in the first 3 hours, and then usually max 40 nanograms per kilogram per minute thereafter. Okay, you're usually titrating to try to target a MAP greater than 65 millimeters of mercury. This is particular for patients in septic shock. This is what's most classical. Okay, and then it's most often given through a central line rather than a peripheral IV. This is a newer medication, so there's not a robust pool of evidence here, either for giving it peripherally or the dosing or what have you. So we definitely need more evidence to help drive some of these claims. But as it goes right now, it's preferred to be given through a central line. We already talked about the dosing, and high doses beyond 80 nanograms per kilogram per minute are not recommended because, as we'll talk about, there is a thrombotic risk, an increase in venous thromboembolism and blood clotting. Again, we'll talk more about that. The pharmacokinetics here, angiotensin II starts working within minutes, so it's very fast on, and its half-life is only 30 seconds. So this is fast. This is faster than most of the other vasopressors. So once you turn it off, it is out of your system almost immediately. All right, you have to give it through a continuous infusion because of that. And it's rapidly degraded by enzymes in the blood. So it doesn't depend on liver function. It does depend on renal function to metabolize it. Now, inactive metabolites are cleared renally. So if you have renal dysfunction, you won't urinate out those metabolites, but they're inactive metabolites. They're not contributing to the angiotensin II pathway of vasoconstriction and aldosterone secretion and all that kind of stuff. Some patients with liver and renal function, certain vasopressors, things like vasopressin, might stick around longer because of the way it's metabolized and excreted. But in angiotensin II, it is rapidly degraded by enzymes in the blood, so you don't have to worry about liver or renal dysfunction. And then the inactive metabolites are renally excreted, but those are inactive. Clinical uses, indications, and kind of notes and thoughts. Well, the main one is refractory vasodilatory shock or catecholamine refractory hypotension. These are similar-ish in what we're talking about here. So in patients unresponsive to norepinephrine and vasopressin, and sometimes even a third vasopressor like epinephrine or something is put on, but those patients unresponsive to those, there is a soft suggestion to trial angiotensin II. Now again, we need more evidence here to do good evidence-based medicine. Maybe starting it earlier is better. Maybe starting it with a different combination of vasopressors is better. We just don't know because this is a newer drug. But at this point, it's kind of a third or fourth line vasopressor in terms of when you start it in these patients. Post-cardiac arrest vasoplegia, it's sometimes given, and then RAS blockade overdose. This is interesting, right? If someone overdoses on their ACE inhibitor, they take too much of it. It's theoretically useful in ACE inhibitor toxicity, although the data is limited. But as we said, it works downstream of the ACE. So it theoretically should be extra effective in working in these patients, whereas other vasopressor medications may be less effective. But the main thing is third or fourth line here for vasodilatory shocks, such as septic shock, after you've already trialed. First line, which is norepinephrine, and second line, which is vasopressin, and sometimes even a third line like epinephrine. The evidence here that we've been talking about, again, is not robust. The main trial is ATHOS-3, and it was published in the New England Journal of Medicine in 2017, and it looked at angiotensin II versus placebo in patients with vasodilatory shock requiring high-dose vasopressors. But what they looked at for the primary outcome was just if the MAP went up at hour 3. It didn't look at, mortality or long-term outcomes or any of that. It just looked at if it increased the MAP. And in 70% of patients, angiotensin II did increase the MAP compared to 23% in the placebo group. So it does seem that angiotensin II does increase the mean arterial pressure. It does increase the blood pressure. But whether it affects mortality or not is tough to say, okay? They did look at secondary outcomes. There was no significant difference in 28-day mortality, but this was a secondary outcome. There's some suggestion that maybe in those who were on lower doses of vasopressors when it was started, they might have had a mortality benefit, but lots more that would need to be studied there. Okay. The risk that was noted in this trial was there was an increased risk of thrombosis in the angiotensin II group. There's increased incidence of things like deep vein thrombosis and pulmonary embolism, all things kind of venous thromboembolism. So one should be cognizant of that. If a patient cannot tolerate, DVT prophylaxis with sub-Q heparin and those types of things, or there are increased risk for clotting, angiotensin II does increase that risk further. So certainly something to be aware of. The Surviving Sepsis campaign does recommend considering angiotensin II in patients with refractory shock, not responsive to norepinephrine and vasopressin. So as we've been talking about, kind of that third or fourth line, consider it. It's very expensive, which is one of the big barriers at this point. No strong mortality benefit. Side effects and complications, as we talked about, one of the bigger ones here is thrombosis. Things like deep vein thrombosis, arterial thrombosis, pulmonary embolism. Some people even suggest considering concurrent anticoagulation. We don't personally go that far, not that this is any medical advice, but you should be hesitant or cognizant of using angiotensin II in patients that you cannot prophylax for DVTs with because of whatever reason. Like many vasopressors, you can get digital or mesenteric ischemia, especially at higher doses. You can get actually reflex hypertension if you titrate it too quickly. And then the aldosterone effect can theoretically contribute to volume overload, right? Because that aldosterone, stimulating aldosterone secretion increases sodium and water retention and thus increases intravascular volume. But that risk is probably not super, super robust. Okay. The manufacturer, just so everyone knows, does recommend VTE prophylaxis during infusion due to this elevated thrombotic risk. So if we compare angiotensin II with two of our main other vasopressors, being norepinephrine and vasopressin compared to angiotensin II. So receptor targets. Angiotensin II, the main receptor it targets is that AT1, causing vascular smooth muscle vasoconstriction. Whereas norepinephrine targets the alpha and beta 1 receptors, those catecholamine receptors, alpha 1 in the blood vessels and beta 1 in the heart. And then vasopressin targets the V1 receptor, which also causes vascular smooth muscle vasoconstriction. So all three, AT1, alpha-1, and V1, all cause vasoconstriction, but all do it through different mechanisms. Angiotensin II is not a catecholamine, vasopressin is not a catecholamine, nor epinephrine is a catecholamine. The arrhythmia risk for angiotensin II causing arrhythmias is low. The arrhythmia risk for vasopressin is low. The arrhythmia risk for norepinephrine is moderate. Epinephrine is high, right? Because norepinephrine and epinephrine do have some beta-1 adrenergic effects on the heart that can increase our risk for arrhythmias. So the risk of thrombosis is high in angiotensin II, and it's low in norepinephrine and vasopressin. Those don't tend to increase risk for thrombosis. Lactate elevation, angiotensin II, norepinephrine, and vasopressin, none of them cause a lactate elevation. Epinephrine does cause a lactate elevation. And then use case for angiotensin II is really refractory shock, third or fourth line. Use case for norepinephrine is first line in septic shock, and use case for vasopressin is second line in septic shock. All right, so you have someone in septic shock, norepinephrine's first line, vasopressin second line, and angiotensin II could be considered a third or fourth line. So clinical summary of angiotensin II. The class of the medication it's a synthetic peptide hormone targeting the RAS system. Its brand name is Giopreza. Its usual ICU indication is refractory septic or vasodilatory shock. The dose range is 20 to 80 nanograms per kilogram per minute, but after 3 hours, max of 40. Main adverse effect is thrombosis. Onset of action is minutes. The main trial on it is the ATHOS-3 trial. So consider from a teaching standpoint of adding angiotensin II if MAP is less than 65 despite norepinephrine and vasopressin being on, and there's concern that there could be catecholamine resistance or limited receptor responsiveness. Always consider DVT prophylaxis during angiotensin II infusion due to the thrombosis risk, and be cautious in patients with known hypercoagulable states. So hopefully that was helpful. So Midodrine as an oral vasopressor. We're going to get more into that, but we're going to start with its mechanism of action, some of the explanation behind how it works. So Midodrine is actually a prodrug, meaning Midodrine in and of itself does not do much. It has to be metabolized to its active form, okay? And this metabolization happens in the liver, where Midodrine is metabolized to its active form, known as desglimidodrine. We might have pronounced that wrong. Any pharmacists in the crowd, let us know. Desglimidodrine. And this active form, desglimidodrine, acts as a selective alpha-1 adrenergic receptor agonist. And if you've checked out any of other episodes on vasopressors, you'll recognize some of the words in here. But we're going to go through it. So first is alpha-1 receptor. So the alpha-1 receptor is a catecholamine or catecholaminergic or adrenergic receptor. Those are all synonyms, right? And alpha-1 receptors tend to be part of smooth muscle receptors, and smooth muscle coats are blood vessels. So when the alpha-1 receptor is stimulated, it leads these smooth muscles to constrict, and that can cause vasoconstriction, right? So the stimulation of that alpha-1 receptor causes vasoconstriction, and that vasoconstriction leads to an increase in systemic vascular resistance, which often leads to an increase in the mean arterial blood pressure, the blood pressure in general. So Midodrine's active metabolite, desglimidodrine, being a selective alpha-1 adrenergic receptor agonist, which means it stimulates it, leads to vasoconstriction. All right. So desglimidodrine stimulates peripheral alpha-1 receptors on arteriolar and venous smooth muscle, leading to vasoconstriction. Something to point out here is that it acts on both arterial and venous smooth muscle. So you get both arterial vasoconstriction and venous vasoconstriction, which will come into kind of its hemodynamic effects that we'll talk about in a little bit. So this, as we mentioned, increases systemic vascular resistance, which can increase the blood pressure, the mean arterial pressure. It does not cross the blood-brain barrier, so there's actually no central adrenergic stimulation. For those unfamiliar, adrenergic, this word we keep talking about, refers to kind of catecholamine-based mechanisms of action. So adrenergic, catecholaminergic, catecholamine-based vasopressors are all kind of synonyms. We've talked about in some of the previous episodes that there's kind of two broader categories of vasopressors. There's the adrenergic and the non-adrenergic. And the adrenergic work on catecholamine receptors. These are things like norepinephrine, epinephrine, phenylephrine, and midodrine. The non-adrenergic or non-catecholaminergic vasopressors have different mechanisms, just mechanisms that don't base themselves on catecholamines. These are things like vasopressin, angiotensin II, methylene blue, hydroxocobalamin. We've talked about all of these in our vasopressor episode, so check those out if you have more interest. But midodrine is a catecholaminergic or adrenergic based oral vasopressor. It does not have any significant beta adrenergic effects, right? There's beta 1 and beta 2 receptors as well. Beta 1 typically increases cardiac output and can increase heart rate, whereas beta 2 actually typically causes vasodilation. Beta 1 receptor effects are present on epinephrine, norepinephrine, but midodrine does not have these effects. It also has no dopaminergic effects or cardiac inotropic effects, so it really does not directly affect the heart. It indirectly affects the heart, which we'll talk more about, but it does not directly affect the heart. It's a pure alpha-1 agonist. It vasoconstricts the peripheral vasculature without having effects on the heart otherwise. So the net effect here, just to be repetitive, to really drive home the point, is midodrine causes an increase in systemic vascular resistance, which can lead to an increase in mean arterial blood pressure, and it does not directly affect the heart. So dosing and pharmacokinetics. As we mentioned, midodrine is oral. This is unique for vasopressors. There aren't really oral vasopressors otherwise. All these other ones we've talked about are intravenous or IV vasopressors. This is an oral vasopressor for all intents and purposes. The oral dose typically used is anywhere from 2.5 to 10 milligrams orally every 8 hours or TID. You will at times see someone go up to as high as 20 milligrams, but most typically 2.5 to 10 milligrams orally every 8 hours or TID, right? 3 times a day. The peak effect occurs within 1 hour after the oral dose. So do remember that this isn't immediate. It's oral. So you got to swallow the pill, you got to digest it, absorb it, and the midodrine itself is not active, right? It's a prodrug. So you also need to wait for the midodrine to be converted in the liver into its active metabolite before you see any effect. So you really need to wait 1 hour before you see an effect. The half-life of the active metabolite, the desically midodrine, is about 3 to 4 hours, which makes sense that we dose it TID or every 8 hours, because the half-life is about 3 to 4 hours of the active metabolite. So, that will be, they say, about 5 half-lives before you fully get rid of all the drug, and you dose a TID because that'll be a couple of half-lives, so it works its way out. The bioavailability is fairly good, so anytime you have an oral drug, you're curious how much of that drug that you take is going to be bioavailable. How much do you absorb, right? And the bioavailability of midodrine is about 93%, so it's really well absorbed orally. You absorb most of the midodrine that you take in. It's metabolized, as we talked about, in the liver hepatically to the active metabolite desically midodrine. So if you have severe liver dysfunction, you might not be as able to metabolize that prodrug to the active form, so it might not be as effective. And then you excrete the active form in the kidneys. It's renally excreted. So if you have renal dysfunction, the midodrine might stick around a lot longer, and it might start to kind of stack doses because you're not able to excrete that active metabolite through the kidneys because your kidney dysfunction. So there's something to be said. If in patients with kidney dysfunction, continue adjusting the dose in renal impairment, because you can risk accumulation. If it does accumulate, you can actually get hypertension, which we'll talk more about down below. So consider starting with lower doses in those with renal dysfunction. So the indications, well, the FDA-approved indication, which is not what this episode is about, is for symptomatic orthostatic hypotension. And this is patients who have kind of autonomic failure. So sometimes you can get atrophy of your neurologic system, or there's other things like diabetic neuropathy that can cause autonomic failure. We're not going to talk much about it here, but some people at home are on midodrine. Some of you watching this may be on midodrine at home. And this is what the medication is FDA approved for. But there are off-label uses, and this is what we mostly see in the emergency department or intensive care unit. And the first is this idea, and we're going to get more into this, but that you can use oral Midodrine as an adjunct to try to wean off your intravenous vasopressor. So let's say you're on intravenous norepinephrine at low doses. If you're not doing weight-based, it's something, let's say you're on low single-digit norepinephrine, something like 2 or 3 micrograms per minute, and you've been on it for a little while. The patient's been critically ill for a little while. You think you fixed or are fixing the primary cause of that persistent hypotension, but they've been on these intravenous vasopressors for a handful of days. Some folks will start oral Midodrine with the goal being to try to come off that intravenous norepinephrine so that they're not stuck on this intravenous drug. That sometimes can help you transfer a patient out of the intensive care unit. You don't have the complications of being on an intravenous vasopressor. If your institution mandates that these vasopressors go through a central line, even at low doses, you won't have to leave a central line in because they'll be on oral Midodrine, all under the assumption that the oral Midodrine does help you wean off the intravenous vasopressor, which is a big if. So this is the primary use in the ICU, but there's lots of variability in terms of how people approach this. Some people believe in it and do it all the time. So if you're on persistent low-dose norepinephrine, you are fixing the problem. Some people will every time put the patient on oral Midodrine to try to wean them off their low-dose intravenous norepinephrine. Other people don't believe in this, right? Other people think this is the wrong thing to do, and they won't ever give someone oral Midodrine to wean off intravenous vasopressors. So lots of variability here, and there probably isn't a right answer yet. Hopefully more evidence to come in the future that'll help guide us, and we'll go into the evidence that exists down below. Other off-label uses, hepatorenal syndrome, again, not going to talk about it here, but this peripheral vasoconstrictor can sometimes shunt blood towards the kidneys in patients with hepatorenal syndrome who get this persistent vasoplegia. Neurogenic shock or spinal cord-induced hypotension. Sometimes these pure alpha-1 receptor agonists like Midodrine can be nice drugs over the long term because you have some degree of inability, some vasoplegia persistent after spinal cord injuries that you might have to be on oral Midodrine. Dialysis-induced hypotension, you'll see this a lot. Some patients have to take Midodrine before dialysis because when they're getting dialysis, their blood pressures will drop. So some patients are on kind of PRN Midodrine to be taken before dialysis. Refractory hypotension in palliative care, we don't really see this as much. We're going to cross that out. Not sure what to do with that. Contraindications or caution. So when should you think about not giving Midodrine or being careful with Midodrine? And it's probably not full contraindications, it's probably cautions would be more accurate. When do you want to be cautious with giving Midodrine? Well, severe heart disease, because you're actually increasing afterload. This is a pure alpha-1 agonist, so all this drug is doing is increasing the systemic vascular resistance. So that's increasing the pressure the heart has to pump against. And if you have severe heart disease, this can cause the heart to actually go into cardiogenic shock and start to struggle to pump against that afterload. Acute renal failure, you have to be careful, right? Because doses will accumulate, because as we talked about, the active metabolite of Midodrine is renally excreted. So severe acute renal failure, you won't be excreting that active metabolite. Urinary retention. The mechanism of Midodrine can actually cause sphincter constriction too, so it can worsen urinary retention. So you got to be cognizant of that. If you have a patient who you take the Foley catheter out and they still have persistent urinary retention and they're on Midodrine, this could be a cause of it. And then things like pheochromocytoma and thyrotoxicosis, all these things where a pure alpha-1 receptor agonist can sometimes cause these patients to get worse. You got to be a little bit careful. Other things to think about is supine hypertension. This drug can cause supine hypertension, right? Patients, when they lay down, can sometimes have this severe reflex hypertension when they're on Midodrine. So some people even suggest not giving the drug before a patient goes to bed because that patient will then lay down and can sometimes get this high blood pressure when they're laying down. Coronary artery disease, for the same reason we talked about organic heart disease. Arrhythmias, and this is not all arrhythmias, this is really bradycardic arrhythmias, because Midodrine, since it increases this afterload and does increase systemic vascular resistance as well as mean arterial pressure, sometimes that can actually cause bradycardia. The heart sometimes slows down because the MAP and the SVR have gone up. So any bradycardic arrhythmias, you have to be careful. And then we already talked about renal impairment too. You can get some accumulation in those with renal disease. So one of the big things to take from this is supine hypertension is a major risk, so just be cognizant of that. And some suggest you shouldn't give Midodrine before bed, and that patients should remain upright after dosing for a period of time, although we don't personally tend to go that far. Adverse effects, there's going to be some overlap here. So one of the main ones to think about is the supine hypertension. This is most common, and it can be severe. Those blood pressures can go way, way up. Midodrine can also cause paresthesias, particularly tingling or itching of the scalp and limbs. So that is sometimes something that can occur. Urinary retention, as we talked about, it can cause urethral sphincter or bladder sphincter constriction, which can then lead to urinary retention. This is especially worse in patients with BPH or benign prostatic hyperplasia, men, obviously. It can cause goosebumps and piloerection due to the alpha-1 effects. Piloerection is where the hairs on your extremities stand up. Bradycardia, this is a reflex vagal response to the blood pressure elevation, which is why you got to be careful in giving this in patients with bradycardia. And then rarely can actually cause arrhythmias, usually with higher doses of QT prolonging drugs. This is not common, though, at all. The ones that we feel like we kind of monitor the most for are bradycardia, urinary retention, and supine hypertension are the three that we tend to monitor for the most in the intensive care unit. So what are the hemodynamic effects? If we just summarize all of them, we've kind of talked about them in different sections in here, but let's just get them all in one place. So the main hemodynamic effect is it increases systemic vascular resistance, which then increases the MAP, the mean arterial pressure. As we said, though, it has no effect on the heart because it does not affect beta receptors, which are receptors in the heart, particularly beta 1, right? The MAP and SVR because of the alpha 1 receptor that it affects, but it does not affect the heart. With that being said, though, it does increase afterload, which is what we're giving it for, right? That's the whole point, to increase SVR and to increase MAP, but that can increase afterload on the heart. And by increasing afterload in the heart, it can sometimes cause the cardiac output to go down if it's a patient with heart failure or severe heart disease, right? So it doesn't directly affect cardiac output, but in the wrong patient, a patient who can't tolerate that increase in afterload, it can cause cardiac output to decrease. All right. The heart rate, too, it does not have a direct effect on the heart, but sometimes patients can have a reflex bradycardia that occurs. Okay, so it can sometimes decrease heart rate, although that's a secondary effect, not a direct effect. And then we talked about how alpha 1 receptors affect both arterial as well as venous systems. So it does cause an increase in venous tone, which will increase the preload to the heart. All right, so those are the main hemodynamic effects. Increases SVR, increases MAP, increases preload. No direct effect on the heart rate or the cardiac output, but it could decrease the heart rate through reflex bradycardia and decrease the cardiac output because it has increased your afterload. Hopefully that makes sense. Not too complex, but let us know in the comments if you have any questions on that. What are some of the studies here? Well, the summary here is that there's no right answer here. We don't know if giving Midodrine to help wean off vasopressors is helpful, is hurtful, or what the right thing is. Of some of the studies available, there's one study in 2013 by Levine et al. Published in Critical Care Medicine. It was retrospective, so it was looking back in time at ICU patients that were started on Midodrine during vasopressor weaning. So these patients, someone decided to start them on Midodrine, and then these researchers went back in the charts and looked at the patients that were started on Midodrine. And they did find there was a decreased ICU vasopressor duration, although no change on ICU length of stay or mortality, and then no major adverse effects. So this retrospective study showed that maybe Midodrine does help wean off IV vasopressors, but this was retrospective, and there's lots of shortcomings and biases that can happen in retrospective studies. So there was then another study called the POVER study published in JAMA in 2020. And this was a randomized control trial. So this design was better. These were patients that they randomized from 132 ICU patients who are on low-dose vasopressors. They randomized them to get Midodrine 20 milligrams TID versus placebo. All right. And they found there was actually no difference in time to vasopressor discontinuation. So it did not help wean vasopressors faster. There's no mortality benefit. And there was more bradycardia in the Midodrine group. So their summary actually was that Midodrine did not reduce vasopressor duration and did lead to increased bradycardia. Anytime you see more side effect in a test population, that's always almost a good sign to some degree, because you know that this drug causes bradycardia, So you would expect to see bradycardia, and if, everything else is balanced equal, the fact that the Midodrine group had more bradycardia is actually suggestive that things were well controlled in this trial, because you're seeing the expected side effect in the trial group. So this POVR study was a much higher, still small, right? Still only 132 patients, but it was higher quality than that retrospective study from 2013 we talked about, and there's no difference here, and there's just more bradycardia, so it was not effective in weaning vasopressors. This is another trial on use of hepatorenal syndrome. We'll probably skip that one, but then there was a meta-analyses that have come out between 2020 and 2023, and really the summary here is mixed evidence. We don't know. It seems like it's relatively safe, maybe more bradycardia. It might reduce vasopressor duration in some patients, although it's unclear if that's even true, and there's been no consistent mortality benefit or length of stay benefit in ICU. So unfortunately, the big summary here is we do not know if Midodrine helps us wean vasopressors more quickly or decreases ICU length of stay. It might not. Very helpful, we know. So what are some clinical pearls just in general before we get into the practice questions? Well, Midodrine is not a substitute for intravenous vasopressors in acute shock. Midodrine is not a treatment for acute shock. We want to repeat that. We want to drive that home. Midodrine is not a treatment for acute shock, right? You can consider Midodrine for patients recovering from shock who are on stable, low doses of vasopressors, and you can consider starting it in these patients as a way to try to facilitate ICU discharge or weaning off their low-dose vasopressors. But even this is unclear if Midodrine helps this, right? The studies are unclear if Midodrine is effective for this, but this is the patient population you can consider trying it in. Okay. Consider avoiding dosing within 4 hours of bedtime because of that risk of supine hypertension. Monitor MAP, heart rate, urinary output after initiation, right? This can cause reflex bradycardia, it can cause supine hypertension, and cause urinary retention. And then for hepatorenal syndrome, it's typically combined with octreotide and albumin, but again, we're not really talking about hepatorenal syndrome in this episode. All right, you guys ready for some practice questions? We're going to have a beginner, intermediate, and advanced question. What we're going to do is we're going to read the question and answers. Then we're going to pause just briefly, and then we'll go to the answer. So if you need more time to think, just pause the episode and then restart it when you're ready to hear the answer. So question number 1, beginner level. What is the primary mechanism of action of Midodrine? A, beta-1 receptor agonist that increases heart rate. B, PDE3, phosphodiesterase 3 inhibitor that improves contractility. C, alpha-1 agonist, increasing peripheral vascular tone. Or D, dopamine agonist, increasing renal perfusion. All right, pause here if you need more time. The answer is C, alpha-1 agonist, increasing peripheral vascular tone. So Midodrine we know is a prodrug. Its active metabolite, though, after it's converted to this in the liver, is a pure alpha-1 receptor agonist, which leads to vasoconstriction and increased MAP. Bonus points. Can anyone think of which vasopressors are beta-1 receptor agonists that would increase heart rate? Lots of them. Norepinephrine does. Epinephrine does. Those are probably two of the bigger ones. What about phenylephrine? Nope. Phenylephrine is a pure alpha-1 agonist. Exactly right. All right, bonus points again. What is a phosphodiesterase 3 inhibitor that improves contractility? Milrinone. Good. Speaking of which, you should have put Dopamine up here as a beta-1 receptor agonist. And what about a dopamine agonist that increases renal perfusion, which isn't really even a real thing anymore? This would be dopamine, which we talked about in an episode, although dopamine is really not used much at all anymore. All right, question number 2, intermediate level. A 72-year-old ICU patient on norepinephrine at 2 micrograms per minute is otherwise stable and ready to transition out of the ICU. The team considers starting Midodrine. Which of the following is the primary rationale for this choice? A, to improve cardiac contractility. B, to prevent further hypotension due to bradycardia. C, to facilitate weaning off IV vasopressors. Or D, to prevent acute renal failure. Pause here if you need more time. The answer is C, to facilitate weaning off IV vasopressors. In select ICU patients, Midodrine has been used to increase SVR and maintain MAP as an oral vasopressor to wean off the IV vasopressors. Right? Evidence, unclear if this works or doesn't work, but this is how it is used. Bonus points. What improves cardiac contractility vasopressor-wise? Norepinephrine, epinephrine, milrinone, which is an inotrope technically, dobutamine, which is an inotrope technically. What prevents further does Midodrine improve or potentially worsen bradycardia? Midodrine potentially worsens bradycardia, so it would not prevent further hypotension due to bradycardia. And then does Midodrine prevent acute renal failure? No, right? Midodrine actually is renally excreted, so in patients with renal failure, it can lead to accumulation of doses that can lead to worsening side effects. All right, last question, the advanced level. A 58-year-old man with decompensated cirrhosis and rising creatinine is oh, we forgot we made this hepatorenal syndrome. Apologies. Well, bear with us. If you all want an episode on hepatorenal syndrome, let us know. A 58-year-old man with decompensated cirrhosis and rising creatinine is diagnosed with hepatorenal syndrome. The ICU team plans to start albumin and octreotide. What is the rationale for adding Midodrine in this setting? A, to increase splanchnic vasodilation and improve liver perfusion. B, to reduce aldosterone-mediated sodium retention. C, to increase systemic vascular resistance and improve renal perfusion. Or D, to stimulate renal dopaminergic receptors. Even though we didn't talk much about HRS, you could still get this question just based on what you know about Midodrine. All right, pause here if you want more time. The answer is C, to increase systemic vascular resistance and improve renal perfusion, right through that alpha-1 receptor agonism. In HRS, Midodrine counteracts the systemic vasodilation that happens with cirrhosis and helps redirect perfusion to the kidneys. Good job. So in summary, Midodrine is an oral alpha-1 agonist. It is a prodrug that is converted into its active metabolite in the liver. In the ICU, it is sometimes used as a bridge to get off low-dose stable IV vasopressors. The typical dose is 2.5 to 10 milligrams orally 3 times a day. Some people go up to 20 milligrams orally 3 times a day. The peak effect does not occur for 1 hour, so you got to be patient. It can cause supine hypertension. It can cause urinary retention. It can cause paresthesias. Be cautious in patients with renal impairment as it is excreted in the urine. So those with renal dysfunction, it can accumulate. And evidence for its effect as a bridge to wean off vasopressors is very limited. Moderate is too strong here. We're going to say weak evidence. Cool. That's all we have for you today.
Let's dive in. Methylene blue as a vasopressor, starting with mechanism of action. So methylene blue can act as a selective inhibitor of nitric oxide. And nitric oxide causes vasodilation. So 2 main mechanisms at play here. One is inhibition of nitric oxide synthase. So this is what creates nitric oxide. So this will then decrease nitric oxide production. The other thing that methylene blue does is it inhibits soluble guanylyl cyclase, which will decrease cyclic GMP, and it will decrease smooth muscle relaxation. So there's a nitric oxide dependent mechanism, and then there's this other kind of CGMP mechanism, but both of them lead to less vasodilation or smooth muscle relaxation, which if it's less vasodilation and less smooth muscle relaxation, that will obviously increase systemic vascular resistance and increase your mean arterial pressure, at least theoretically. So methylene blue is particularly interesting in patients where you think they have high nitric oxide mediated vasodilation. Some of these patients are patients with, cirrhosis or liver disease, are sometimes at particular risk for this. But we'll talk about if there's ever any evidence to support its use, although we do use it. So the net effect here for methylene blue is that it reverses vasoplegia by reducing pathologic vasodilation, increasing systemic vascular resistance, and thus raising the mean arterial pressure, or the MAP. So indications in critical care, this gets a little tough, right? Methylene blue is not, and we want to emphasize, is not a first-line agent. But it is sometimes considered as what we call rescue therapy for that kind of refractory vasoplegia. That patient who's on 1, 2, 3 vasopressors, and they still have hypotension. Sometimes you'll think about methylene blue as a rescue therapy. As we mentioned, vasoplegic shock, especially post-cardiopulmonary bypass or post-liver transplant, sometimes you could trial methylene blue. Refractory septic shock that does not seem to be responding to catecholamine vasopressors like norepinephrine and vasopressin. There's some growing literature or interest, I suppose we should say, in using methylene blue in anaphylactic shock that's unresponsive to our first line being epinephrine. And then there's also some attention in using methylene blue in refractory hypotension from either calcium channel blocker or ACE inhibitor overdose. So these last two are interesting. We don't want to say new, but somewhat newer thoughts and approaches, whereas more classically, methylene blue is considered in vasoplegic shock and refractory septic shock. When we're dosing methylene blue, a lot of folks do this IV bolus where you give 1 to 2 milligrams per kilogram over 10 to 30 minutes, and then you try to see, did they respond? Okay? If there's no response, then most of the time, you don't go on an infusion because you say you didn't respond to methylene blue. If you do respond, some people then do an infusion of methylene blue at 0.25 to 2 milligrams per kilogram per hour over several hours. We don't tend to do that. We usually stick with a bolus, but there is an optional infusion. The onset's within 30 minutes. Duration can last 2 to 4 hours, although there's some variability here. But most folks will do the bolus and see if there is a response, if they're a methylene blue responder. Pharmacokinetics, you can only give it intravenously. It's widely distributive and it does cross the blood-brain barrier. It's metabolized by your liver and it's excreted urinary through your kidneys, so you urinate it out. And it does cause, this is always a fun thing to ask the trainees on rounds, it does cause blue-green urine discoloration. So in the Foley bag, the urine will be a blue-green color. Half-life is 5 to 24 hours, which can be somewhat significant. That's why we tend to stick to like a bolus, because if they respond, there will be some circulating for a little bit because the half-life's a little longer. Contraindications and precautions. So if a patient happens to have G6PD, glucose 6-phosphate dehydrogenase deficiency, they're missing this enzyme, you do have a risk of hemolysis giving methylene blue. Okay, this can be really serious. But there's no good way to know ahead of time if the patient has G6PD deficiency, unless obviously they know when they tell you, because to test for this, it's a send-out lab that can take days to come back. So there is some risk here. If someone has G6PD deficiency, you don't know it, and you give them methylene blue, they can get severe hemolysis. You also can get serotonin syndrome. Methylene blue is a weak monoamine oxidase inhibitor, and if they're on other serotonergic medications, obviously, things like SSRIs, serotonin reuptake inhibitors, fentanyl has some serotonergic effects, which can be used to treat pain in the ICU. There's a whole slew of other serotonergic medications, but if you combine methylene blue with these, you actually can induce serotonin syndrome. Again, all these things are rare, but they can happen. And then don't give it to pregnant patients. It can cause deformities. Teratogenicity would be the more appropriate term than what we said. So be very hesitant in pregnant patients. We personally don't give it at all. Be knowledgeable that it can cause serotonin syndrome and it can cause hemolysis. In patients with renal dysfunction, you got to be a little careful because you do risk accumulation because it is renally excreted. And then something that we think a lot about in our clinical day-to-day is there is some risk of pulmonary hypertension because it leads to an increase in pulmonary vascular resistance, right? So that right ventricle has to pump against more afterload. And if someone has right ventricular failure, that can cause them to get sicker rather than better. So cautious in renal dysfunction. I tend to avoid it in patients with pulmonary hypertension because I think the risk outweighs any potential benefit. Know that it could cause serotonin syndrome and know that it can cause hemolysis too. Adverse effects, we kind of just talked about this, but just to spell them out a little bit more. Potential adverse effects include serotonin syndrome, hemolytic anemia in those with G6PD deficiency, blue-green urine, although this is completely harmless. It's just something to pimp your trainees about on rounds. Pulmonary vasoconstriction, which can worsen RV failure. Skin staining, if it extravasates, it can cause tissue discoloration.
And then hypoxia artifacts. Sometimes this interferes with the pulse oximeter, so you can get falsely low readings. So if you give methylene blue and you see the pulse oximeter drop, that might be falsely low, and you should get an arterial blood gas to further clarify, because it might not be a real reading. All right, so these are all the things to kind of keep in mind when you're giving methylene blue as all potential adverse effects. The studies on methylene blue, what we first want to say here is all these are very limited. There are no excellent trials to suggest we should be giving methylene blue. There are some smaller trials though, right? And we're not going to go through all these, but just to note, methylene blue versus placebo after cardiac surgery. The methylene blue group had faster MAP recovery and reduced vasopressor needs. There was a critical care medicine study in 2020 that looked at catecholamine refractory septic shock, so those patients on high doses of vasopressors but were still in shock, and they gave methylene blue and it reduced norepinephrine requirements and improved hemodynamics. Various reviews show that there probably is a role in post-cardiopulmonary bypass vasoplegia, most effective early. And then again, this is ACE inhibitor-induced vasoplegia. Methylene blue seems to be effective. So it seems like the most evidence is in cardiovascular surgery patients. There's some evidence in septic shock, and this is nowhere near all the trials. It's just kind of a random assortment. But the summary is in someone with refractory hypotension who is failing catecholinergic vasopressors and they're in septic shock, you could consider giving this, although the evidence is very limited. The sample sizes are small. Most of them are single institution. Most of them are not randomized controlled trials, and there's many limitations to the evidence out there. And there's real side effects too. You got to always take that into account. There's real adverse reactions that can occur. Comparison to other vasopressors. This is probably not something worth us totally reading out, so we could pause it here for those watching the video. For those of you who listen to the podcast, you can hop over to the video if you're interested. It's just a table comparing norepinephrine to vasopressin to epinephrine to dopamine to milrinone to angiotensin II and now methylene blue. So it goes through the primary mechanisms of each, the effect on heart rate, and the ideal use case, with methylene blue's ideal use case being primarily refractory vasoplegia refractory to catecholamines. So we'll let you all digest that on your own. Okay, let's get into some practice questions. The way the practice question is going to work, we actually usually do 3 practice questions. There's 10 here. So let us know if this is helpful or hurtful. We're going to go through each one. Right when we're done reading the potential answers, we'll kind of give you a chance to pause if you want to think about it more, and then we'll just dive into the answer. It's divided up into beginner, intermediate, and advanced. So starting with beginner question number 1. What is the main mechanism of action of methylene blue in vasoplegic shock? A, alpha-1 receptor stimulation. B, PDE3 inhibition. C, nitric oxide pathway inhibition. Or D, V1 receptor activation. Pause here if you want. Going into the answer. The answer is C, nitric oxide pathway inhibition. So if we go, what we're going to do is go through all the answers to talk about why C is the correct answer. So alpha-1 receptor stimulation, this is actually phenylephrine as a vasopressor, has pure alpha-1 receptor stimulation. Then norepinephrine and epinephrine have some alpha-1 receptor stimulation. Methylene blue does not. PDE3 inhibition, this is milrinone, an inotrope. All right. Remember, methylene blue has nitric oxide pathway inhibition, nitric oxide scavenger. And then V1 receptor activation is vasopressin for its mechanism of action. All right, question number 2. What is a common side effect of methylene blue therapy? A, hyperkalemia. B, green-colored urine. C, bradycardia. Or D, QTC prolongation. Pause here. We're going to go into the answer. The answer is B, green-colored urine. So as you mentioned, green-colored urine is a harmless side effect of methylene blue. Pretty much everyone gets it. Hyperkalemia is not a common side effect of methylene blue, or really many other vasopressors either. Epinephrine can actually cause some hypokalemia. Bradycardia, sometimes you can get reflex bradycardia from phenylephrine as a pure alpha-1 agonist. That increase in MAP can sometimes cause reflex bradycardia. And then QTC prolongation is not common in different vasopressors. So green-colored urine, side effect of methylene blue, harmless. Okay, question 3. What clinical feature would contraindicate methylene blue use? A, COPD, B, cirrhosis, C, G6PD deficiency, or D, diabetes? All right, going into the answer, pause if you want. The answer is C,
G6PD deficiency. So remember, those with G6PD deficiency, methylene blue can prompt a hemolytic crisis or hemolysis. And you want to really avoid that. But again, many times you don't know this ahead of time. COPD, if you had severe pulmonary hypertension from COPD, methylene blue maybe wouldn't be the best choice, but just classic COPD, not a big deal. Cirrhosis, methylene blue is sometimes anecdotally more efficacious because cirrhotics sometimes have more nitric oxide circulating, and methylene blue is a nitric oxide scavenger. And diabetes, no contraindication of methylene blue with diabetes. All right, are we into intermediate? Yes, intermediate question number 1. Why might methylene blue be favored in post-cardiac bypass vasoplegia? A, it increases cardiac output via beta-1 agonism. B, it reverses cGMP-mediated vasodilation from excess nitric oxide. C, it improves oxygen delivery by increasing hemoglobin. Or D, it inhibits aldosterone release. All right, going into the answer. The answer is, drum roll please, B. So it reverses cGMP-mediated vasodilation from excess nitric oxide. This is the mechanism of methylene blue. And this is sometimes deranged in patients who had undergone post-cardiac arrest bypass. So it directly addresses that possible derangement. A, it increases cardiac output via beta-1 agonism. This is like the inotrope dobutamine. Epinephrine does this as well. Norepinephrine does this to a small degree, but methylene blue does not affect beta-1. It is not a catecholaminergic mechanism. C, it improves oxygen delivery by increasing hemoglobin. No, this would be blood transfusion, packed red blood cells. Vasopressors don't do this. D, it inhibits aldosterone release. So angiotensin II increases aldosterone release. It does not. D, methylene blue is not involved in this pathway. All right, question 5. A patient on fluoxetine develops agitation and clonus after methylene blue infusion. What is the diagnosis? A, neuroleptic malignant syndrome. B, malignant hyperthermia. C, serotonin syndrome. Or D, anticholinergic toxicity. All right, pause if you want. The answer is C, serotonin syndrome. So as we mentioned, methylene blue is serotonergic. So if it is given with other serotonergic medications like fluoxetine and SSRI, it increases the risk for serotonin syndrome. Serotonin syndrome is usually fevers, agitation, clonus, tachycardia, hypertension. Clonus is one of the big clinical exam things. If we have a patient we're worried for serotonin syndrome, the first thing we do is we go and we, do the foot flapping maneuver to see, it probably has a better name than that, to see if we can elucidate any clonus. Neuroleptic malignant syndrome, this is usually from antipsychotics. It has a lot of the same symptoms of serotonin syndrome, except you don't get clonus. You usually get rigidity. Malignant hyperthermia, this is high fevers, and this is usually from anesthesia, not classically methylene blue involved. Anticholinergic toxicity would not be fluoxetine or methylene blue. They do not have cholinergic effects. All right, question 6. What effect does methylene blue have on pulse oximetry? A, falsely high. B, no effect. C, falsely low. Or D, intermittent readings only on toes. All right, pause here if you want. Answer is C, falsely low. So we know that methylene blue can cloud or make pulse oximetry on the fingers inaccurate, mostly from color changes, because SpO2 pulse oximeters use color waveform to get their SpO2. So methylene blue can throw that off and cause falsely low SpO2. All right, question 7. We're into advanced now. In a patient with septic shock on high-dose norepinephrine and vasopressin, which lab result supports initiating methylene blue? I'll give you a hint. We actually can't really test for this in most places, but our shop in particular. A, low cortisol. B, high plasma renin. C, elevated nitric oxide metabolites. Or D, high lactate with low SCVO2. All right, answer is C. Methylene blue, we know, is a nitric oxide scavenger. It inhibits the production of nitric oxide, and nitric oxide causes vasodilation. So if someone has high nitric oxide metabolites, methylene blue may be particularly useful in reversing the vasodilation from nitric oxide. Question 8. Methylene blue is ineffective in which of the following? A, catecholamine-resistant vasoplegia. B, shock secondary to spinal cord injury. C, nitric oxide-induced hypotension. Or D, post-cardiopulmonary bypass vasoplegia. All right, answer is B. So remember methylene blue, it is really good for nitric oxide induced hypotension because of its mechanism. The evidence suggests it's good in post-cardiopulmonary bypass vasoplegia because these patients have increased nitric oxide circulating. There's some evidence that catecholamine resistant vasoplegia, methylene blue is effective. But in shock secondary to spinal cord injury, this is not a nitric oxide mediated pathway, and as such it's not thought to be effective, right? Because this is a kind of sympathetic pathway derangement because you injured your high C spine, not nitric oxide related. All right, question 9. What is a known pulmonary risk of methylene blue? A, pulmonary hemorrhage. B, hypoxia due to hemoglobinemia. C, pulmonary vasoconstriction exacerbating RV failure. Or D, bronchospasm. All right, answer is C, pulmonary vasoconstriction exacerbating RV failure. So we know methylene blue increases pulmonary vascular resistance, and as such can lead to pulmonary vasoconstriction, and it can worsen RV failure. So patients with RV dysfunction from ARDS or chronic RV dysfunction from pulmonary hypertension, you have to be really careful with methylene blue. Methylene blue does not cause bronchospasm. We should circle the right answer. Methylene blue does not cause pulmonary hemorrhage, and it does not cause hypoxia due to hemoglobinemia. All right. Is that it, or do we have one more? One more. Question 10. Which combination has most likely produced a dangerous drug reaction? Methylene blue and Midodrine, methylene blue and linezolid, methylene blue and norepinephrine, methylene blue and lactated ringers. Ooh, this is a good question. I forgot about this one. All right. Correct answer is B, methylene blue and linezolid. So linezolid actually is a weak monoamine oxide inhibitor. So this increases the risk for serotonin syndrome. So methylene blue and linezolid together just increases the risk for serotonin syndrome. And that was the root of the question. So methylene blue and Midodrine doesn't increase the risk for anything. Norepinephrine, no. Lactated ringers, no. In fact, you give methylene blue with all those medications without much issue. Let's dive in. So overview of hydroxocobalamin. What is it? Well, it's actually a form of vitamin B12. And most traditionally, it was used to treat cyanide toxicity. However, as time has gone on, it's emerged as a potential rescue vasopressor for refractory vasoplegic shock. Now, we'll be the first to say, we actually don't tend to use this in the clinical arena, but there are people that do, and there is some evidence to guide its use, but it's really in those refractory cases. Patients who are on multiple vasopressors, they're still vasoplegic, and you just cannot get their blood pressure up. So mostly refractory to conventional vasopressors is when you start thinking about hydroxocobalamin use. Its vasoconstrictive properties are tied to nitric oxide scavenging, and this is not dissimilar to another salvage therapy known as methylene blue. We actually have talked about this in one of our other vasopressor and inotrope episodes. Definitely check that out. We got a whole series on vasopressors and inotropes. So diving into the particular mechanism of action of hydroxocobalamin, its primary effect as a vasopressor is through the scavenging of nitric oxide. So nitric oxide binds and causes vasodilation. So nitric oxide as a molecule causes vasodilation. So what hydroxocobalamin does is it binds nitric oxide, and when it binds nitric oxide and decreases the amount of functional nitric oxide, that decreases soluble guanylate cyclase, or SGC activation. That then decreases cGMP, that decreases the amount of vasodilation and increases vascular tone, thus possibly increasing mean arterial blood pressure. Okay, so this is like a confusing mechanism. You don't really need to know the mechanism for the clinical arena that much, but just know that it's a nitric oxide scavenger, and since nitric oxide causes vasodilation, by scavenging up all that nitric oxide, that will increase vascular tone, increase vasoconstriction, and potentially increase MAP. But patients who have nitric oxide dysfunction or have more nitric oxide radicals floating around, cirrhotics or patients with liver disease are one of these populations. They might be particularly prone to showing improvements after hydroxocobalamin. The secondary effects, which is more
Related to other modalities is it may bind hydrogen sulfide, which is another vasodilator. It might reduce carbon monoxide, which is another vasodilator, and it may enhance the response to catecholamines like norepinephrine and epinephrine. So a couple competing potential pathways here. It's unclear whether these pathways are that robust. The main one here is the nitric oxide scavenging pathway when it comes to hydroxocobalamin's use as a vasopressor. So dosing, so typically you give a single bolus dose of 5 grams infused over 15 to 30 minutes. Do you know this is off-label, right? It's not approved for this use. This is an off-label use. You can repeat this bolus dose if the patient is a responder, if they improve and then they need it again. So most people give the bolus dose and then see if the patient responds to it. Maximum total dose is not well established. Some case reports use up to 10 grams, so this 5 grams times 2. We tend to just use it once and see if they're a responder or not when it is used in the clinical arena. So hydroxocobalamin is a single bolus or short infusion, 5 grams over 15 to 30 minutes. It is not a continuous drip. So this is not an infusion. It's a bolus or a short infusion, which is kind of just a bolus over a short period of time rather than a continuous drip. Pharmacokinetics. The half-life of hydroxocobalamin is quite long. It's 16 to 30 hours, but the onset is within minutes. So this kicks in within minutes, but the half-life sticks around for a little bit. So the duration is quite variable. Some patients have vasopressor effects that last for several hours post-infusion or post-bolus, whereas others don't. So the variability here is hard to predict, but this is not, it turns off and immediately the effect goes away. It's some period of hours that it will have its effect for. The excretion is primarily renal, and this turns your urine reddish up to several days. This is in comparison to methylene blue, MB methylene blue, which causes urine to be a kind of green-blue color. So hydroxocobalamin, urine turns reddish. Methylene blue, urine turns green-bluish. Indications for our intents and purposes are refractory vasoplegia. Right, so these are patients post-cardiopulmonary bypass. Post-cardiopulmonary bypass, you tend to have increased nitric oxide radicals around, which is why hydroxocobalamin may be particularly useful. Septic shock, unresponsive to norepinephrine and vasopressin. This is really for salvage therapy. Patients who are really sick on super high doses of multiple vasopressors, you can trial a dose of hydroxocobalamin as salvage therapy, although again, the evidence is not strong here. This is off-label use. Anaphylaxis-related hypotension, this is something people are starting to think more about. So if you give epinephrine multiple times, put them on a drip for patients in anaphylactic shock and they still have hypotension, you could consider trialing hydroxocobalamin. A lot of these, if you notice, are very similar to the indications for methylene blue, which again is something we've talked about as well. Liver transplant and trauma patients with profound vasodilation, something to think about. It hurts our soul to see trauma patients on there, but supposedly out in the world, people are thinking about that. Cyanide toxicity is what hydroxocobalamin is FDA approved for. So at your institution, you got to be careful, right? Because if this is what you use to treat cyanide, you probably only have limited stores of this, and if you start using it left and right for hypotension, you could use up all the hydroxocobalamin and then not have it available to treat what it is approved to treat, which is cyanide toxicity. So just remember, this is all opportunity cost. There's a risk benefit to all these things. Contraindications and cautions. So absolute contraindication is, as one would imagine, known hypersensitivity to hydroxocobalamin or cobalt, so if they have a known allergy. Relative cautions, renal impairment, we see this a lot. High doses can rarely cause oxalate nephropathy, so you got to be careful because you can lead to nephropathy in these patients. It also can interfere with certain lab tests because of the color difference, and then it can mask genitourinary bleeding as well because the urine turns red color. So these are just some relative cautions or things to keep in mind. All right, adverse effects. Common ones are the red discoloration of urine, but it can also cause red discoloration of skin and bodily fluids that can last up to 7 days. And you can actually, from the vasoconstriction, get rash, headache, and hypertension. So just something to keep in mind. These are not that serious. Right? Red color of stuff, some headache, all things considered not that serious. There are serious conditions though, they're just much more rare. We talked about the oxalate nephropathy and the acute kidney injury that can result, so really be cognizant of that. You can have anaphylactoid reactions to hydroxocobalamin, and then it can interfere with dialysis circuits. There's sensors on the dialysis circuit that respond to colors, and the discoloration that hydroxocobalamin can cause can interfere with the dialysis circuit and cause it to keep going off. This is not every circuit. You'd have to check with your dialysis circuit brand to see if it's one that would have issue with their sensors after hydroxocobalamin. But if someone is on continuous renal replacement therapy or CRT, something we've talked a lot on the channel about, and we got lots of episodes out there on that. But some CRT machines will have issues and will kind of have error messages pop up if you give hydroxocobalamin because it messes with the medical sensors because of the discoloration. There is some evidence out there. All this evidence is very weak evidence, tons of limitations. So just, know that if you are going to be using this drug. But there have been a handful of trials out there, right? There's one in 2016, 2022, 2020, 2021. And a lot of them show improvement in MAP, reduced vasopressor needs, post-cardiopulmonary bypass vasoplegia, hemodynamic improvement in patients with vasopressor refractory vasoplegia, nitric oxide scavenging and vasoplegic shock, potential benefit in catecholamine-resistant septic shock. But all these are small. None of them are RCTs, and none of them are multi-center. A lot of them are case reports, case series, observational data. So all incredibly limited, and we need really large-scale RCTs to know whether this is truly effective, especially for clinically meaningful outcomes like mortality and things. All right, clinical pearls. Consider hydroxocobalamin for refractory vasoplegia, post-cardiopulmonary bypass, septic shock, all that good stuff. Beware of false lab values due to the red dye. This is especially for co-oximetry, your creatinine, your bilirubin, all these will be thrown off. Great option for patients with circulatory collapse where nitric oxide overproduction is suspected. Same thing with methylene blue, another one. All right, should we get into the practice questions? I think we got 3 practice questions, 1 beginner, 1 intermediate, 1 advanced. We'll read the question, we'll read the answers. Then if you need time to think, pause because we'll go right into the answer. Question number 1, beginner question. What is the primary mechanism by which hydroxocobalamin acts as a vasopressor? A, beta-1 adrenergic stimulation. B, alpha-1 agonism, C, nitric oxide scavenging, or D, vasopressin receptor activation. All right, pause here if you need time. The answer is, drumroll please, C, nitric oxide scavenging, right? Just like methylene blue, hydroxocobalamin scavenges nitric oxide radicals, which then causes more vascular reactivity and vasoconstriction can ensue. Beta-1 adrenergic stimulation, these would be things like dobutamine, epinephrine, norepinephrine. Alpha-1 agonism would be things like phenylephrine, norepinephrine, and epinephrine have alpha-1 agonism effects as well. Vasopressin would be vasopressin, which makes sense. All right, intermediate question. A patient undergoing a liver transplant develops vasoplegic shock unresponsive to norepinephrine and vasopressin. You consider hydroxocobalamin. What lab artifact would you expect after administration? A, hyponatremia. B, hyperkalemia. C, falsely low bilirubin. Or D, interference with co-oximetry. Pause here if you need a minute to think about it. The answer is D, interference with co-oximetry. So we know that hydroxocobalamin does affect certain labs. It does not affect the sodium. It does not affect the potassium. It does interfere with co-oximetry. It also interferes with bilirubin, but it's not low, okay? It would be high. It interferes with creatinine and some other stuff too. All right, advanced. Last but not least, which of the following best describes a potential complication of high-dose hydroxocobalamin? A, methemoglobinemia, B, oxalate nephropathy, C, bradycardia, or D, hypocalcemia. Pause here. Answer is B, oxalate nephropathy. So as we talked about, oxalate nephropathy is a known risk of hydroxocobalamin. All right, methemoglobinemia is not bradycardia. It does not affect the heart rate. And hypocalcemia, it does not affect the calcium levels. So oxalate nephropathy is a described complication of high-dose hydroxocobalamin. Dive into dopamine. So starting with mechanism of action, how does dopamine work? Well, dopamine is a dose-dependent adrenergic and dopaminergic agonist. Lots of big words here. So dose dependent, that one's obvious. Different doses cause different things to happen. We'll talk about that. Adrenergic. This is something we've talked about in previous episodes on vasopressors. And adrenergic means catecholamine based. The mechanism of action uses catecholamine receptors, right? These are things like norepinephrine, epinephrine, phenylephrine, and now dopamine as well. And then dopaminergic, it acts on dopamine receptors as well. An agonist means it stimulates said receptors. So it is a dose-dependent adrenergic and dopaminergic agonist. So going into its mechanism of action a little bit more, there's some dose-dependent nature to this, right? We kind of talked about that a little bit. And these doses are in micrograms per kilogram per minute. In 0.5 to 2 micrograms per kilogram per minute, tends to act on dopaminergic receptors, D1 and D2. These are primarily in the kidneys. And it causes some renal-based vasodilation and theoretically increased urine output. Back in the day, there was this idea that dopamine is renal protective. You can use it for kind of renally dosed dopamine to protect the kidneys or improve renal function, but this isn't really supported by evidence any longer. So this renal dosed dopamine certainly isn't used, or I guess we should rephrase, there's no evidence or guidelines to recommend its use in this fashion. All right, so that's 0.5 to 2 micrograms per kilogram per minute. A little bit above that is 2 to 10 micrograms per kilogram per minute. And this is where it starts to act more on beta-1 receptors. As we've talked about in previous episodes, beta-1 receptors act on the heart, right? So the heart has beta-1 receptors, whereas alpha-1 receptors act on the blood vessels, which we'll get into. So at 2 to 10 micrograms per kilogram per minute, it primarily affects beta-1 receptors. It still has some dopamine D1 and D2 receptor effects. But the beta-1 receptors being in the heart do increase heart rate and increase contractility, which then increase cardiac output. Okay, and that is true, right? At these 2 to 10 micrograms per kilogram per minute doses, it affects beta-1 receptors more than the dopaminergic D1 and D2 receptors. And these beta-1 receptors in the heart increase heart rate, increase contractility, increase cardiac output. As we continue going up on doses to more than 10 micrograms per kilogram per minute, you start to get more alpha-1 receptor effects over beta-1. You no longer are getting those dopamine receptor effects. So more than 10 micrograms per kilogram per minute of dopamine, you get primarily alpha-1 effects with a minority or a lower amount of beta-1 effects. So this is when alpha-1 on the blood vessels leads to vasoconstriction that increases your systemic vascular resistance, which then increases your blood pressure, your MAP, through vasoconstriction. It still has a little bit of the cardiac beta-1 effects, increasing heart rate, contractility, and cardiac output, but it primarily increases your blood pressure at these higher doses. And this will be important when we talk about indications, because there's going to be some dose-dependent indications here as well. So dosing and pharmacokinetics. Typical dosing range, although this is more theoretical, people use all sorts of different doses, but it's 2 to 20 micrograms per kilogram per minute. We talked about how that 0.5 to 2 was the old school kind of renal dosing that works on dopamine receptors in the kidneys. That is no longer a thing. So 2 to 20 micrograms per kilogram per minute, with the first 2 to 10 primarily being beta-1 receptor effects, and then greater than 10 being primarily alpha-1, at least more than beta-1 receptor effects. Onset is 5 minutes, half-life's 2 minutes, so it's fast on, fast off. Now, fast on does not mean instantaneous, right? It takes about 5 minutes to kick in. So if you were to start something like dopamine, you have to wait a little bit before we see its full effect. Just like norepinephrine is about 2 minutes. If you start norepinephrine and you give it 10 seconds and then you start increasing it and increasing it, you won't really see what that dose did, and you'll probably end up causing some hypertension because you probably up-titrated doses too quick. So onset of action for dopamine is 5 minutes, half-life's 2 minutes. It is metabolized hepatically as well as renally, so in the liver and kidneys through the MAO and COMT mechanism. So if you have significant liver or kidney dysfunction, This can lead to longer half-lives because you won't be able to metabolize it as fast, and it's excreted in the urine. But the metabolites are excreted in the urine, right? It was already metabolized to its inactive metabolites that are then peed out. Duration is short, duration of action, so you need a continuous infusion. This is a continuous IV infusion of dopamine. You're not bolusing it or, giving it PRN. It's continuous infusion. You usually titrate it based on your hemodynamic goals, often guided by cardiac output, blood pressure, perfusion indices, if you're going to use it, which is a big if, which we'll talk more about. So indications. In the ICU, our humble opinion, which is just our opinion, we pretty much never use dopamine. I can't think of the last time I used it in the clinical arena. There's one small exception where, in our humble opinion, it's still reasonable, and that's the bradycardic patient at those low doses, those 2 to 10 microgram per kilogram per minute doses. Dopamine is reasonable to use because at this dose, it's primarily beta-1 effects, which will increase your heart rate. Now, epinephrine is just as good, so we tend to use epinephrine, but dopamine, it's reasonable to use for bradycardia with hypotension. Some people still use it in cardiogenic shock, right, at those 2 to 10 microgram per kilogram per minute doses, primarily affecting beta-1 receptors, although we don't tend to do that. Historically, it was used in septic shock, but this is not really done anymore. Evidence would suggest that this is a worse option than norepinephrine, so you should just use norepinephrine, not dopamine in septic shock. And then symptomatic hypotension, this isn't really a thing anymore either. So this is not commonly used, with the one caveat being, and although we don't do it because we would just use epinephrine, that you could consider using it for bradycardia at those lower doses. Contraindications and cautions: you should be careful in patients with pheochromocytoma because the alpha-1 effects. Allergy to sulfites. Some formulations of dopamine have sulfites in them. And then dopamine is really bad for causing tachyarrhythmias, so you got to be really careful with that. It can cause ischemia of the mesenteric digits, just like many vasopressors, especially if a patient has severe hypovolemia. Can really then lead to worsening ischemia, so make sure your volume replete if you were to use this for some reason. Adverse effects, as we talked about, tachycardia given the beta-1 stimulation, and arrhythmias, particularly ventricular arrhythmias, are a big thing. Arrhythmias are one of the reasons that we choose norepinephrine over dopamine in many of these cases. It can cause myocardial ischemia, which any drug that is going to have beta-1 receptor action that then increases contractility, it can have some worsening myocardial ischemia because you're asking that heart muscle to squeeze harder, and when it squeezes harder, it uses up more oxygen. So that's not particular to dopamine. If dopamine is going through a peripheral IV and it extravasates, it gets out of the IV into the subcutaneous tissue, you can get extravasation injury through its alpha-1 mediated vasoconstriction, common of many vasopressors, which is why most of the times we're putting these through central lines, although there is some blossoming evidence on the safety of peripheral vasopressors, particularly norepinephrine. That is in a different episode, though. Nausea and headache. Dopamine can cause nausea and headache through CMS stimulatory effects. Reduced GI perfusion. It vasoconstricts the splanchnic circulation, the circulation around the bowels, that can cause reduced GI perfusion, which can lead to mesenteric ischemia. Again, many vasopressors, norepinephrine and vasopressin, do this too, although dopamine is definitely a culprit. If you get extravasation injury, you treat that with phentolamine. Just a little shout out to that, although we're not going to go too much more into that. Hemodynamic profile. What are the actual hemodynamic effects of dopamine? Remember, this is dose dependent. That's the whole story here with dopamine, dose dependent. So at higher doses, that greater than 10 micrograms per kilogram per minute, it primarily has alpha-1 effects that increase SVR, systemic vascular resistance, and increase the MAP, the mean arterial pressure. At those medium doses, 2 to 10 micrograms per kilogram per minute, it primarily has beta-1 effects, which are going to increase heart rate and increase contractility. At those low doses that we don't recommend anymore, 0.5 to 2 micrograms per kilogram per minute, there's that theoretical increase in renal perfusion, but that is not a real thing. It's not clinically supportive anymore. So hemodynamically, increase SVR and increase MAP at higher doses, increase heart rate and contractility at lower doses. The studies that have helped inform our use of dopamine, one is the SOAP2 trial in the New England Journal of Medicine in 2010 that compared dopamine versus norepinephrine, and the dopamine group had more arrhythmias, and there was no mortality benefit with dopamine. So norepinephrine was preferred over dopamine in most shock states because there's less arrhythmias. The renally dosed dopamine, there's a meta-analysis in the 2000s that showed no benefit of low-dose dopamine in preventing acute kidney injury. That's why it's not recommended anymore. There's a dopamine versus epinephrine in neonatal shock trial published in the New England Journal of Medicine in 2011. Dopamine was associated with lower mortality compared to epinephrine in septic shock, but this is specific to pediatrics and not generalizable to adults. We don't take care of pediatric patients, so we don't know all the details of that, so we're going to cross it out, and you'll have to do more research on that yourself. When we get to clinical pearls on dopamine, dopamine is not favored to be used in ICU practice. It is more arrhythmogenic. It can cause ischemia. It is not recommended in septic shock. You could consider dopamine at lower doses, 2 to 10 micrograms per kilogram per minute, in symptomatic bradycardia with low MAPS, just as a bridge to whatever you're going to do to fix that heart rate. That's not unreasonable, although we usually use epinephrine instead. If you are using dopamine, watch out for peripheral ischemia, and central access is key, especially at moderate to high doses, because extravasation can be limb-threatening. So in summary, dopamine is an endogenous catecholamine. It primarily works on catecholamine receptors, beta-1 at 2 to 10 micrograms per kilogram per minute, and alpha-1 at doses higher than 10 micrograms per kilogram per minute. The onset of action is about 5 minutes, so you need to give it a couple minutes before you see its effect. Typical dose is 2 to 20 micrograms per kilogram per minute. The arrhythmia risk is very high, and this whole idea that it helps renal perfusion is not clinically borne out in trials. Some practice questions, 3 of them, starting with beginner. We'll do the practice questions as we always do. I'll read the question and the answers. I'll say quickly, pause if you need more time, and then I'll go into the actual answer. So if you need more time, make sure to pause it because we'll go right into the answer. Beginner question level number 1. Beginner level question number 1. That makes more sense. Which of the following best describes the receptor effects of dopamine at doses between 2 and 10 micrograms per kilogram per minute? A, pure alpha-1 stimulation. B, pure beta-2 stimulation. C, predominantly beta-1 stimulation. Or D, predominantly dopaminergic stimulation. Pause here if you need more time. The answer is C, predominantly beta-1 stimulation. So at this range, dopamine increases inotropy and heart rate via beta-1. Right? Pure alpha-1 stimulation tends to be greater than 10 micrograms per kilogram per minute. It does not cause beta-2 stimulation, and then predominantly dopaminergic stimulation is that 0.5 to 2 micrograms per kilogram per minute, although there's no reason to use it at these doses anymore because it is not shown to be renal protective. All right, intermediate level question. Which of the following is a major reason dopamine is no longer preferred as first-line vasopressor in septic shock? A, it causes hyperkalemia. B, it lacks any beta-adrenergic activity. C, it has a higher risk of arrhythmias. And D, it improves renal perfusion too strongly. All right, pause here if you need more time. The answer is C. It has higher risk of arrhythmias. Remember that SOAP2 trial published in the New England Journal of Medicine showed that there was more arrhythmias and adverse effects with dopamine as compared to norepinephrine, which is why we use norepinephrine for these patients. It does not cause hyperkalemia. It does have beta-adrenergic activity, right? Those doses between 2 and 10 micrograms per kilogram per minute are primarily beta-1 effects. And then it improves renal perfusion too strongly is just a ridiculous answer, but even the whole thought that dopamine can improve renal perfusion is no longer borne out as true. Last question, the advanced level. A patient in cardiogenic shock has a MAP of 68 millimeters of mercury and a heart rate of 48 beats per minute. You are considering dopamine versus norepinephrine. What factor might favor dopamine in this case? A, risk of renal injury. B, need for alpha-1 mediated vasoconstriction. C, coexisting bradycardia. Or D, risk of tachyarrhythmias. Pause here if you need more time. The answer is C, coexisting bradycardia. So the one time in which we say you could consider dopamine, although we do not do this in our practice, is bradycardia. Dopamine may increase heart rate in patients with bradycardia, making it temporarily helpful, potentially, as a chronotrope or a drug to increase heart rate. None of the other answers useful, and even this for us, we do not do this, but we at least wanted to put something in there for how you could potentially consider using dopamine. That's all we have.
What is epinephrine to start? Well, epinephrine is actually also known as adrenaline, depending on where you practice. It actually might primarily be called adrenaline. And this is a potent endogenous catecholamine. And when we're talking about vasopressors, if you've checked out any of our other past vasopressor videos, you'll hear us talk a lot about catecholamine or catecholaminergic or adrenergic. All these are synonyms for vasopressors that work on catecholamine receptors. Things like norepinephrine, epinephrine, phenylephrine. This is in comparison to non-catecholamine-based or non-adrenergic vasopressors, things like Vasopressin, Angiotensin II, Methylene blue, Hydroxocobalamin. Again, all different vasopressors we're talking about in this vasopressor series. But there's kind of two different categories. So epinephrine is a catecholamine vasopressor, a catecholaminergic or adrenergic vasopressor. It acts on catecholamine receptors. Particularly two that we talk most about with vasopressors being the alpha and beta adrenergic receptors, which we're going to talk more about. Epinephrine is widely used in shock states, cardiac arrest, and anaphylaxis. It plays a significant role in the management of refractory hypotension in the ICU, and it's definitely one we need to know about. What is interesting about epinephrine, especially compared to norepinephrine, its sister vasopressor, is that epinephrine actually has mixed inotropic and vasopressor properties. Inotropic meaning increasing cardiac output, so affecting the heart more, and vasopressor, which means increasing the mean arterial blood pressure or affecting the blood pressure more. So it has this mixed effect, which we're going to talk more about. And that mixed effect comes from its mechanism of action. So the receptors that epinephrine acts on are, I don't want to say different than norepinephrine, but the ratio and how strongly it affects different receptors is different. So when we talk about the two different receptors, I'm going to draw a blood vessel covered by kind of smooth muscle here. So there's a blood vessel covered by smooth muscle that is coating the blood vessel, and then we'll draw a heart too. Excuse our bad drawings. That's a heart. Right atrium, right ventricle, left atrium, left ventricle. If you're listening to this in podcast form, you're not missing much on these drawings, but you can always hop over to the YouTube video. So epinephrine works on the beta-1 receptor. Beta-1 is a receptor in the heart that increases contractility and increases heart rate. So it has inotropic effects, which is an increase in contractility, and it has chronotropic effects, which is an increase in heart rate. Whereas the blood vessels have alpha-1 receptors, and alpha-1 causes vasoconstriction of the blood vessels in that smooth muscle. So it vasoconstricts. So if we talk about epinephrine in particular, epinephrine has beta-1 effects on the heart, which increases heart rate, that chronotropic effect, increases contractility, that inotropic effect, and both of these lead to increased cardiac output. So this beta-1 effect by epinephrine is this inotropic effect, all right? It also, though, does affect alpha-1 receptors on blood vessels that cause vasoconstriction, increase in systemic vascular resistance, and increase in the mean arterial blood pressure. Epinephrine also has this beta-2 effect on the lungs. We're not going to spend much about it, but it can cause some bronchodilation. This is why you can use epinephrine to treat refractory bronchospasm and asthma. And epinephrine can cause a lactate elevation. So when a patient is getting epinephrine, it most likely will cause a lactate elevation. Now, this elevation, if you have someone on epinephrine and their lactate is going up, you shouldn't just bank on it being because of the epinephrine. You should make sure the lactate isn't increasing for other reasons, but epinephrine does and will cause some degree of lactate elevation. But primarily beta-1 effects and alpha-1 effects. Now, these are dose-dependent, which we're going to talk more about in dosing and administration. So, when it comes to mechanism of action, epinephrine increases the MAP, the mean arterial pressure, through the alpha-1 receptor and increases cardiac output through the beta-1 receptor. But it also can cause hyperlactatemia, It increases myocardial oxygen demand because of that beta-1 effect, making the heart squeeze in over time. And it increases the risk of tachyarrhythmias like atrial fibrillation and SVT because of that beta-1 chronotropic effect. So good things, but also a more robust side effect profile. Again, all things we'll talk more about in the video. So dosing and administration of epinephrine. When it comes, we're going to divide this up into 3 different clinical scenarios. The first one being shock, the second one being cardiac arrest, and the third one being anaphylaxis, because they all require a slightly different approach. So in shock, epinephrine is a continuous infusion. It's weight-based, meaning its units are micrograms per kilogram per minute. Now, some institutions take the kilograms out, and they do non-weight based, all right, just in micrograms per minute. But most institutions, it's in micrograms per kilogram per minute. And you start at 0.01 to 0.05 micrograms per kilogram per minute, all right? And the titration range is then 0.05 to 0.3 micrograms per kilogram per minute that you titrate it to. Now, all this is not a perfect science, right? Some places will titrate to much higher doses of epinephrine than other places. There's probably a peak epinephrine dose that is no longer effective above that dose, but what that is really tough to say. All right. Most places do suggest a central venous catheter to give epinephrine. You probably can give it through peripheral IV if you're doing it in the right way, but only for a limited period of time. And there's really just not a lot of evidence in giving epinephrine peripherally. So more to come on that as evidence evolves. So central line is what's classically recommended here. Now, we do want to point out that different doses of epinephrine have primarily beta-1 effects versus primarily alpha-1 effects. So primarily beta-1 effects, and remember those beta-1 were increasing cardiac output. These are at lower doses of epinephrine. And those lower doses really are somewhere on the specter of that initial starting dose, you know, that kind of 0.01 to 0.05 micrograms per kilogram per minute. Primarily have that beta-1 effect. So if you're starting epinephrine just for something like bradycardia, you're really going to just set it at one of these lower doses, 0.01 to 0.05 micrograms per kilogram per minute. You don't want to titrate it up because the beta-1 effect then turns more into an alpha-1 effect, right? And that alpha-1 effect was vasoconstriction. It would just increase the mean arterial pressure. And this is, quote unquote, higher doses, which is really doses just above that initial starting dose, all right? And we'll talk more about this later on in the video too. So for shock, continuous infusion, 0.01, 0.05 micrograms per kilogram per minute. Best done in a central line, although there's some argument there. Cardiac arrest, you usually are giving a 1 milligram IV push every 3 to 5 minutes per ACLS, Advanced Cardiac Life Support protocols, and this is for all types of cardiac arrest. Now, for ventricular dysrhythmias, there's some argument that after a couple doses of epinephrine, giving more might make the heart have a tougher time getting back into sinus rhythm. But again, not great evidence here. So per ACLS, 1 milligram of epinephrine IV push every 3 to 5 minutes. And then anaphylaxis, you're actually giving it IM, intramuscular, right? This is an EpiPen. If people have heard of EpiPens, hopefully you have. It's 0.3 to 0.5 milligrams intramuscular every 5 to 15 minutes. If it is refractory in our practice pattern to 2 doses, we actually start an epi infusion, which is similar to if patients are in shock, that continuous infusion. But you do want to give it intramuscular. Lateral thigh is a commonplace, 0.3 or 0.5 milligrams every 5 to 15 minutes. And if it's refractory to this, you can change it over to an epinephrine infusion for anaphylactic shock. And again, our practice pattern tends to be 2 intramuscular doses. And if it's still not effective, then we put them on an epinephrine infusion for anaphylactic shock. The pharmacokinetics here are similar to norepinephrine. The onset of action is immediate. It starts working within 1 minute. And then the half-life is only 2 to 3 minutes. So if we think about 5 half-lives, folks say that 5 half-lives is enough for the drug to be pretty much all out of your system. That's just literally several minutes. Somewhere around 10 minutes, the whole drug is gone. So when you stop it, it stops working almost immediately. It is metabolized by the MAO, monoamine oxidase, and COMT enzymes in the liver. So patients with really bad liver function sometimes aren't able to metabolize it as well. And then it's eliminated through the liver and the kidneys, but but with inactive metabolites. Okay, so patients with really bad liver dysfunction, the half-life might be a little bit longer, but not by much, not nearly as much as something like vasopressin. Okay, clinical uses. We kind of talked a little bit about this already. Anaphylaxis is a big one. It's the first-line agent, intramuscular first, followed by intravenous continuous infusion if need be. Cardiac arrest, ACLS algorithm suggests giving it intravenously. Refractory septic shock, it is sometimes given when norepinephrine and vasopressin fail to achieve the target MAP goal. You can consider it. Bradycardia with hypotension might be a nice drug, but remember, this is at those low doses, right? Because you just want that beta 1 effect, somewhere around that 0.01 to 0.05 micrograms per kilogram per minute. And then sometimes post-cardiopulmonary bypass, it's used because it has that inotropic with that beta 1 effect and that vasoconstrictive alpha 1 effect as a vasopressor. What evidence and guidelines do we have on epinephrine? Well, the Surviving Sepsis Campaign recommends epinephrine as a second or third line agent for septic shock after you've already started norepinephrine and vasopressin. It can cause tachycardia, tachydysrhythmias, elevated lactate levels, all reasons that it is not first line in the eyes of the Surviving Sepsis Campaign. ACLS, Advanced Cardiac Life Support, as we talked about, the AHA recommends epinephrine as a cornerstone of cardiac arrest therapy. It improves return of spontaneous circulation, though no consistent survival benefit or neurologic outcome benefit. And this is really interesting if we just go on a little side tangent. In cardiac arrest, epinephrine is like a cornerstone, right? Anybody who's even had a whiff of ACLS training or even basic life-saving training has probably heard of epinephrine. But the data on epinephrine is really old school data. Originally was in like canine models and stuff. And there's not really good evidence to suggest that epinephrine improves our survival or our neurologic outcomes in patients with cardiac arrest. There's actually an old study that looked at escalating doses of epinephrine, starting at 1 milligram and then increasing the dose with each subsequent administration in cardiac arrest. And they got the heart to restart more often, but the neurologic outcomes were way worse. And that's why we don't do it, right? There was no real benefit in long-term survival or functionality. So ACLS, we still are suggesting that you follow ACLS as you should, but it is interesting to think about the evidence behind some of these things we do in cardiac arrest is really, really bad, really, really poor evidence. And we certainly would benefit from more studies on this. It's just a really tough thing to study, right? Comparative studies on epinephrine versus norepinephrine. It seems to have similar MAP effects, but epinephrine can cause more tachycardia, elevated lactate, and potentially some splanchnic ischemia, which is why norepinephrine is our first-line drug as compared to epinephrine. Side effects and complications are similar to a lot of our catecholamine vasopressors. So we already talked about tachyarrhythmias. Because that beta 1 effect of epinephrine, you get more atrial fibrillation, more ventricular ectopy. It also can cause more myocardial ischemia because the beta 1 effect, you're asking that heart to squeeze harder and harder and harder. And while it's doing that, that heart is using more oxygen and it needs more blood flow. So if patients have coronary artery disease, it can increase oxygen demand and cause some degree of myocardial ischemia, like just from a global inability to get enough blood flow to the myocardial tissue. We talked about how it can cause lactic acidosis. Whether that's clinically meaningful or not is tough to say, but the beta 2 receptor effect that it has, remember we didn't focus much on it, but it has beta 2 effect, which can cause bronchodilation, which is why it is sometimes used in refractory bronchospasm and asthma. But that same beta 2 effect stimulates glycolysis, which can lead to elevated lactates. It causes vasoconstriction, so you get the same type of concern for ischemia in the digits or the gut, especially at higher doses. And then beta 2 can also cause hyperglycemia and hypokalemia. Again, not super common things, but it can cause increased lactate, it can cause increased glucose, and it can cause decreased potassium, are the three kind of metabolic things to note for epinephrine. So if we compare epinephrine to norepinephrine, sometimes it's helpful to compare both of these are what type of vasopressors, catecholamine or adrenergic vasopressors, right? These are synonyms, adrenergic and catecholamine. So norepinephrine and epinephrine are catecholamine or adrenergic vasopressors. So epinephrine has beta 1 effects and alpha 1 effects more than these mild beta 2. Beta 2 were for bronchodilation and increasing lactate and increasing glucose and decreasing potassium, whereas the beta 1 is the cardiac effects, alpha 1 is the peripheral vasculature effects. Norepinephrine has alpha and beta 1, but the alpha 1 effects are much greater than the beta 1 effects for norepinephrine. Epinephrine increases heart rate. Norepinephrine maybe mildly increases heart rate, but not by much. Epinephrine increases cardiac output. Norepinephrine maybe mildly increases cardiac output, but not by much. Epinephrine does increase lactate. Norepinephrine does not really increase the lactate. Epinephrine has a higher risk of arrhythmias compared to norepinephrine. And epinephrine is second or third line for septic shock, although it is first line for ACLS and cardiac arrest and anaphylaxis, whereas norepinephrine is first line in septic shock. So just a little comparison between the two. So if we were to summarize epinephrine, epinephrine is a catecholamine vasopressor. It works on beta 1 receptors in the heart, alpha 1 receptors in the blood vessels, and beta 2 receptors in the lungs. Its typical use is first line in ACLS for cardiac arrest, first line in anaphylaxis, and then second or third line in refractory septic shock. The usual infusion dose for something like septic shock that you're starting at 0.01 to 0.05 micrograms per kilogram per minute. In ACLS, the push dose is 1 milligram IV every 3 to 5 minutes. And in anaphylaxis, it is 3, oh goodness, did we blank on the dose? You caught us. It is 0.3 to 0.5 milligrams intramuscular that you can give every 5 to 15 minutes. Common side effects are tachycardia, right, because it has those beta 1 adrenergic effects, increased lactate, arrhythmias. Other side effects that are not as common are increasing glucose, decreasing potassium, ischemia of the digits or the mesentery or splanchnic. And then the evidence, there's evidence in ACLS and anaphylaxis, there's mixed evidence in shock, and the evidence in ACLS, as we talked about, you do it, but the evidence is not that strong. All right, that is a summary of epinephrine, part of our vasopressor series. Check out our other vasopressor videos. Phenylephrine. What is phenylephrine? Well, phenylephrine is a pure alpha 1 adrenergic agonist. Let's dissect that a little bit. So pure alpha 1. So this only acts on alpha 1 receptors. And alpha 1 receptors are in blood vessels and they cause vasoconstriction. And we're going to talk more about that later on in the video. So it's pure alpha 1 adrenergic. Adrenergic is essentially catecholamine based. So this is a catecholamine based vasopressor because it works on catecholamine receptors. This gets into, we divide up vasopressors a little bit into catecholamine or adrenergic. These are kind of synonyms in this case. So adrenergic, catecholamine, catecholaminergic, and non-adrenergic or non-catecholaminergic vasopressors. And the catecholaminergic or adrenergic vasopressors are things like norepinephrine, epinephrine, phenylephrine, and all of them work on catecholamine receptors, whereas the non-adrenergic or non-catecholamine vasopressors are things like vasopressin, angiotensin II, methylene blue, hydroxocobalamin, all things we've talked about in this vasopressor inotrope series. So phenylephrine is a pure alpha 1, so it works only on alpha 1 receptors. Adrenergic, so it's a catecholamine-based vasopressor. Agonist, so agonist is that it stimulates these alpha 1 receptors. So pure alpha 1 adrenergic agonists used as a vasopressor, used to increase blood pressure by inducing peripheral vasoconstriction. Unlike catecholamines such as norepinephrine and epinephrine, phenylephrine has no beta adrenergic activity, right? It's a pure alpha 1. Beta adrenergic activity affects the heart and leads to increase in contractility and increase in heart rate, which can lead to increased cardiac output. And norepinephrine, although small, does have some beta activity, and epinephrine has a fair amount of beta activity. So phenylephrine is pure alpha 1. It has no beta adrenergic activity. So it does not directly affect
the heart rate or contractility. Now, directly is really important, and this is something we're going to talk more about because it might actually have some negative indirect effects on heart rate and contractility. So in general, phenylephrine is considered a second or third line agent. This is for things like septic shock. In the operating room, anesthesia tends to use phenylephrine more than our job as intensivists in the ICU tend to use it. There are some particular times in which we do grab for it, though, which again, we'll talk more about. It's particularly useful when tachycardia or tachyarrhythmias make the beta stimulation undesirable. More to come. Mechanism of action, we dived into a little bit. So this is a pure alpha-1 receptor agonist, so it only works on the alpha-1 receptors. And the alpha-1 receptors are in peripheral blood vessels. That's a blood vessel. There's all these smooth muscle on all these peripheral blood vessels. And the smooth muscle can contract and cause vasoconstriction. So the alpha-1 receptors, when they're stimulated, cause that blood vessel to vasoconstrict. And in doing so, it increases the systemic vascular resistance, which increases the mean arterial blood pressure. So this is a way to increase blood pressure, increase MAP. It does not have any beta-1 or beta-2 activity, so there's no direct effect on heart rate or contractility. But the thing to note here is that since it's a pure alpha-1 receptor agonist, it does increase the afterload, so it increases the resistance the heart has to pump against. And this is without at all increasing the contractility. So this sometimes can actually be problematic because this sometimes, especially in patients with cardiac dysfunction, can lead to a decrease in cardiac output indirectly. Right? Because it increases the afterload that the heart has to pump against. And by doing so, sometimes that cardiac output will actually drop. So sometimes indirectly, it can decrease the cardiac output, which can be significant and detrimental in some patients. So dosing and administration, the starting dose is typically 0.25 to 0.5 micrograms per kilogram per minute, with a typical dose range from 0.5 to 5 micrograms per kilogram per minute. This is all kind of soft science, right? There's a whole different range in which you can use. At some dose, it probably does not have much effect giving more, but what that dose is really tough to say. And then central line's preferred, although you can give phenylephrine peripherally through a peripheral IV as long as it's a good, dependable peripheral IV. And then most times you're adjusting to maintain a target MAP of greater than 65. This is particular in vasoplegic shock and septic shock rather than something like cardiogenic shock, which hopefully you're not giving much phenylephrine in cardiogenic shock in general. In the perioperative setting, anesthesia, things like the operating room, gives phenylephrine more often than we do in the ICU. They usually push dose phenylephrine. And you give anywhere from 50 to 200 micrograms IV bolus to temporize the patient. Let's say you're doing procedural sedation and you give that patient propofol and it causes their MAPs to drop. Sometimes you can give kind of a push dose of phenylephrine to try to temporize their blood pressure while the propofol wears off. Now, this still has to be done carefully, right? There's side effects we're going to talk about, but this push dose phenylephrine, neosynephrine the brand name, is more often used than the IV continuous infusion version in the ICU. Pharmacokinetics, onset of action is really quick within 1 to 2 minutes. Peak effect is within 2 minutes. The duration, though, is a little longer. It can last 15 to 20 minutes with a half-life of actually 2 to 3 hours. So this sticks around, unlike a lot of vasopressors. Phenylephrine sticks around a lot longer. So if they get this IV push of phenylephrine and their blood pressure goes up, as one would anticipate it does, you still got to be really careful because this phenylephrine still might wear off. And when it wears off, that blood pressure might drop again because you kind of just masked what was going on. And the half-life of phenylephrine can be 2 to 3 hours. So it might be a little delayed before that blood pressure drops again. So you just got to be cognizant of the half-life of these drugs. And phenylephrine sticks around a lot longer than a lot of our vasopressors do otherwise. It is metabolized in the liver. It's excreted in the kidneys. So patients with severe liver dysfunction or renal dysfunction, you got to be a little bit careful because it might stick around even longer than was previously reported in patients who are unable to metabolize it or excrete it. Clinical uses. Phenylephrine is
often ICU can be used in vasodilatory septic shock if there's tachycardias or arrhythmias limiting other vasopressors, because norepinephrine, oh, that's not a pen, norepinephrine and epinephrine have beta 1 effects, and they can increase the risk for tachydysrhythmias. Now, norepinephrine has very little beta 1 effect, so it's not as common to cause tachydysrhythmias, whereas epinephrine can and does cause tachydysrhythmias. So you got to be a little careful, and sometimes, and we personally don't do this very often, but you could consider starting phenylephrine to decrease your norepinephrine dose to theoretically not lead to as many tachydysrhythmias. But again, the evidence there is very soft. There's not a lot of evidence that bears that out. More common is hypotension during anesthesia, commonly used in the OR or post-intubation hypotension or procedural sedation hypotension to kind of quote-unquote temporize with those IV boluses of 50 to 200 micrograms. Bradycardia and hypotension. Phenylephrine can increase blood pressure, sometimes without exacerbating bradycardia, although that's not necessarily always true. I think for the sake of this, we actually might even cross this out. I don't think that's very helpful in retrospect. Okay, adult adjunct and vasoplegic syndrome, so post-cardiopulmonary bypass or liver transplants, sometimes phenylephrine, again, can temporize the blood pressure, and contrast-induced hypotension. So the summary here is things that are very transient that you expect are just going to last for 20 minutes or so and go away. Sometimes phenylephrine in push dose form, phenylephrine PE, push dose can temporize that patient rather than starting an IV continuous infusion of another vasopressor, but you still got to be very careful with this because that phenylephrine will wear off at some point. Okay, when it comes to vasodilatory shock, sometimes this is a third or fourth line vasopressor realistically rather than a first or second line. The evidence around here, surviving sepsis campaign for septic shock, phenylephrine not recommended a first line because it may reduce cardiac output. Remember we talked about that. It's pure alpha 1. So it increases afterload. And by increasing afterload, this can sometimes reflectively decrease cardiac output, which can be really detrimental in these patients. You may consider it when tachyarrhythmia limits norepinephrine use or salvage therapy as third or fourth line in refractory septic shock. There have been some trials looking at phenylephrine versus norepinephrine, and phenylephrine often causes lower heart rate and higher systemic vascular resistance, and at times it actually reduces stroke volume and cardiac output, especially in septic shock. This is exactly what we were talking about up here, right? It can actually decrease cardiac output, which you want all the cardiac output you can get when a patient is in shock. Neurogenic shock is often pure alpha 1 can be helpful, or sedation-related hypotension, but you could use norepinephrine for all these too. Other than the ease of giving a push of phenylephrine, there's not a lot of times to use it. One of the caveats to this, though, would be, oh, did we not put it up here? Oh, shame on us. Severe aortic stenosis leading to cardiogenic shock. Oddly enough, phenylephrine textbook-wise can sometimes be classically first line, because in severe aortic stenosis, which this would be a whole video in and of itself, let us know if you want us to put together an episode on severe aortic stenosis. But you do not, circle with a cross there, do not want to increase heart rate or contractility all the time in severe aortic stenosis. Sometimes you don't have a choice but to try to increase contractility, but this can be detrimental in severe aortic stenosis because you want as much filling time for the ventricle to try to pump against that gradient. So sometimes phenylephrine is a good first choice in patients with severe aortic stenosis. All right, side effects and complications. Phenylephrine can cause reflex bradycardia, which is why we crossed out that thing above that was talking about heart rate. It can cause reflex barocardia, baroreceptor-mediated slowing of heart rate in response to that pure alpha 1 increase in the blood pressure. It can sometimes cause decreased cardiac output by increasing left ventricular afterload, particularly in patients with LV dysfunction. You got to be really, really careful. You should not be grabbing for this drug in patients with left ventricular dysfunction without being very thoughtful about it. It can cause mesenteric and digital ischemia, like many of the catecholaminergic vasopressors, due to intense vasoconstriction. It can cause hypertension if you don't
titrated appropriately, and if it extravasates into the skin, it can cause tissue necrosis as well, as many of these catecholinergic vasopressors can. So if we compare phenylephrine with norepinephrine and vasopressin, the receptor profile for phenylephrine is pure alpha 1. So this is pure systemic vascular resistance. Whereas norepinephrine is primarily alpha 1 with a little bit of beta 1. And vasopressin is actually non-adrenergic or non-catecholinergic, and it works on the V1 receptor, which also causes vasoconstriction just through a different mechanism. Cardiac output with phenylephrine either doesn't change or actually goes down. Cardiac output with norepinephrine either doesn't change or goes up. And cardiac output with vasopressin doesn't tend to change. Okay, so you got to be careful with phenylephrine, especially with patients with left ventricular dysfunction. Heart rate, you can get reflex bradycardia, and it can decrease the heart rate in phenylephrine. Norepinephrine mildly increases the heart rate through that beta-1 activity, and vasopressin is pretty neutral on the heart rate. Arrhythmia risk, very low with phenylephrine because it does not have beta-1 effect. Arrhythmia risk with norepinephrine is mild to moderate because there is a little beta-1 effect, and arrhythmia risk with vasopressin is very low, again, because vasopressin does not have the beta-1 effect. Phenylephrine can be used for hypotension and tachycardia, although this is like a stupid statement. We're going to cross this out too. And then severe aortic stenosis is one of those indications where you can consider phenylephrine, but it's not really first line for anything other than possibly severe AS in certain situations. Norepinephrine is first line for shock, and then vasopressin is usually an adjunct. It's usually second line for septic shock. Clinical summary of phenylephrine. It is a synthetic alpha-1 agonist. Common use is hypotension that we think is going to kind of be transient or brief, that you can give a bolus of phenylephrine for. The push dose range is 50 to 200 micrograms IV bolus. Onset of action is 1 to 2 minutes, although the duration of action is slightly longer. It can last a couple hours. Mean risk is reflex bradycardia. It can cause a decreased cardiac output to give an increase in the afterload and tissue ischemia like many vasopressors. There's no mortality benefit. It's not commonly used in the ICU. It's much more common in the anesthesia world. So teaching pearls, consider using phenylephrine when you want to raise the blood pressure but avoid stimulating the heart. Tachyarrhythmias being one of those things. Okay. Be cautious in septic shock with impaired left ventricular dysfunction. Phenylephrine may actually worsen perfusion by increasing afterload and decreasing cardiac output. And in perihypotension or any kind of procedural sedation hypotension, procedural, we spelled it wrong, good for us. Push dose phenylephrine is often used to quick onset treat that periprocedural hypotension that can occur.